So in this coming 3 days, hi there, good evening, everyone. And first of all, congratulations for clearing the more difficult part, the theory part. Practicals would be, I think, practical would be easier than theory, provided you know. So, so we would be straight away going into the demo and the explanation itself. And at the final debriefing, post mock test, we will do a very sort of winding class where we will discuss about the very uh, clear, straightforward tips on how to be successful on the exams itself. We did a little bit of program yesterday on the Hyderabad platform. I was there. We discussed certain things, but we will discuss more in more detail, more specifics during the winding up class. As of now, let's go on to the straightforward demo. So the basic rules are that we would do just as long cases, short cases, 5 different tables, and 4 different components of the viva itself, right? So we all know that the tables would be mostly on long cases would be 30 minutes duration, short cases would be 15 minutes, and the tables would be 5 of them, approximate 15 minutes duration, and the 4 components of viva would be of 10 minutes duration. So that's how it would be. And we will conduct 2 sets as a demo. So each set will contain, each set means just and one exam itself. So 2 long case, 2 short case, 5 tables, and 4 vivas, right? And what we would expect that people come forward to volunteer. So each one will take of the viva itself. So in if you see in each set, there are around two, 4, 5, and so 13 people can come forward, and we'll do 2 sets. So I think 26 people can come forward and take a name. Okay. So that's how we would go. So I would thankful Dr. Shweta has come forward. It's optional. You can keep your videos on or a. I am reasonably sure that no one is going to take any unfair means during the demo or mock exams. Then you won't get to know how well you are prepared and on that part. So no point of any proctor monitoring and all others. So you can keep your videos off. But obviously, I will request the examiner to keep their videos on. Right. So that's the very sincere request so that people can understand and your uh, questions very clearly. And after each segment, that means one long case, one short case, and one table and others, we will immediately discuss the answers itself. I will try to moderate most of those say. And if there are any questions left, I will try to answer at the end of the session itself. So today we will do 2 long case, do 2 short case, and if time permits, most likely it would, we will do one set of tables itself. That means 5 different segments of the table. Tomorrow we will do the remaining table, the 2 sets of viva itself, and last day we will complete all the long cases and short cases. So that's it. And in the this is the demo part. And in the mock, all of you will be separately giving to individual examiners set one complete set of exams. So that becomes, though it is uniform, but it would be one-to-one, and you would be analyzed over your performance itself. And that is as good as and as strict as your actual exams would be. And they would be preset uniform so that all of you will get a fair uniform chance to submit for an exams itself. And we would be obviously very, I would say, authentic to that particular set of mock exams itself, so that you are clearly, that in last 15-20 days, whatever time would be remaining, where you have to work hard and how you have to improve itself. So that entire exercise is to give you a overview what is expected in an exams, and where also to give you an idea that where you need to improve yourself. So welcome and all the best. Shubhankar, all yours. I'm just switching my camera. You and Shweta. So next 30 minutes, the examiner and examinee itself. Rest all of you kindly take note how the candidate is doing. If you have to ask any questions, post 30 minutes, you can ask in the chat box. As of now, you are just, rest of you, except Shweta, are just spectators looking into and putting yourself into her chair. If anything you need to add or say, do it yourself. If you need to ask something, put it into the chat box, but post 30 minutes. Keep your questions with you once we start discussing the answers itself. So kindly, all of you, mute yourself. And Shweta, it is optional for you to keep your video on or off. Next.
Okay, thank you, sir.
And the next one, whosoever is, be keep ready. And today we would require so two for long case, two candidates for short case, and I think 5 candidates for the tables itself. So select yes, come forward and volunteer yourself. Otherwise, we will ask you randomly to come forward. So all the best. Shubhankar, start.
My slides are visible or not?
Yes, sir.
Do a full screen.
Full slide.
Just wait.
Shubhankar, you have to put your camera.
Just a minute. Video visible है क्या? नहीं, still now not visible.
Video अभी तक आया नहीं.
Just अच्छा.
What your video? You never put your video on. ठीक है. So it's such a handsome guy. Put your video on and smiling examiner. You won't be expecting in the actual exams itself. But anyway,
The exam you will
at least that advantage.
Past faces examiners. No offending, but it is a true. Okay, so the slides are visible, no?
Yes, sir.
Full
So
screen.
so you ये कौन कर दिया? Yes, this one. Okay. So Dr. Shweta, right? So you have
Yes, sir.
gone to the case history. I think I am just showing it briefly for the mentors, and so can you read it out in short?
Yes, sir. A 18-year-old female presented in emergency department with complaints of upper abdominal pain in epigastric region, multiple episodes of vomiting, shortness of breath, and high-grade fever with chills since last 2 to 3 days. And she was treated at some outside hospital for the same initially, and then she was brought to our center for further management. In personal history, she's non-alcoholic, non-smoker, and she was on some weight loss program, attending strenuous gym sessions for last few weeks, less water intake. And other than that, family history, past medical history, all are not significant. And there is no history of any allergy.
So this
In
is the initial-
vital, sorry, sir.
yeah, please go through the initial vitals and thus
Yeah.
finals.
Vitals at presentation were temperature of 103.6 Fahrenheit, pulse rate 122 per minute, respiratory rate 30 per minute, blood pressure of 130/72, and SpO2 85% on room air, and NIV was applied at ER. Chest bilateral air entry decreased in lower zone. Per abdomen examinations showed soft bowel sounds present, no organomegaly, no tenderness. In CNS examination, no neurological deficit was noted, and in CVS, S1, S2 were normal. In POCUS, cardiac adequate LV function, systolic function, bilateral pleural effusion with left more than right, with multiple B lines in the bilateral upper zone and middle zone, and abdomen mild ascites was noted. In ABJ, pH was 7.35, PaO2 of 55, PaC2 of 52 mmHg, bicarb 27, base excess of -2.8, lactate 3.5, sodium 136, potassium 5, and calcium of 0.8 was noted.
Okay. So you have already gone through the details of the case. Just can you summarize the findings till now?
So the
What is your
patient is,
impression of the patient?
sorry, sir, the last line I couldn't hear.
What is your impression of the patient?
Okay, so she's a 18-year-old female with acute abdomen in epigastric region and fever, and the other assessment from the clinical examination and ABGA, everything is suggestive of acute abdomen, most likely acute pancreatitis, and or other differentials can be there, like of acute abdomen, which can be like peptic ulcer disease or gastritis, or there could be any GI sepsis.
GI sepsis. Okay. But 2-3 days of history. There was no history of diarrhea, vomiting.
The vomiting history is there, diarrhea is not there.
Okay. And any other possible differentials in this patient, 18-year-old?
There could be viral hepatitis, or as there is history of fever and vomiting, it could be dengue.
Okay. So how will you approach this case in the emergency itself? In terms of just organ support, fluid resuscitation, electrolyte management, investigations, what investigation you will send, and what are the initial medications?
First of all, for this patient, I will assess for the vitals, which we have seen, and according to vitals and her clinical condition, we'll start with the resuscitation first, in which I will take the 16 gauge, 18 gauge whiteboard cannula, and I'll start with the fluid resuscitation. And as blood pressure is normal, but there is fever, and there is chance of acute pancreatitis. So in view of that, I will start with the fluids, and simultaneously I will send the investigations, blood investigations, in which CBC, RFT, LFT, amylase, serum lipase, then ECG, ABG, all these routine investigations will be sent.
Why ECG?
Also, there is a tachycardia. Patient is having tachycardia, and so just to have a baseline ECG for further monitoring. And there is
Okay.
fever
Is
also.
having fever, upper abdominal pain.
Yes, sir.
So pericarditis can be a possibility here also, isn't it?
Okay, sir.
Okay. And what fluid you will start?
Initially, I'll start with isotonic fluid in ringer lactate.
Okay. So will you send ABG?
Yes, sir, I will send ABG. As she
Any
has
medications you want to give in the ER itself?
yes, sir. In ER, I'll start with the pain medications, as she is having severe acute abdomen.
So
And
which pain medication will you start?
I will initially start with paracetamol injection. And
So, okay. So won't you be giving any opioids in this patient?
yes, sir, if the pain is very severe and it is not controlled with paracetamol, we can give opioids. We can give
So any
tramadol
pain
or
assessment
fentanyl.
tool that you know of?
Sorry, sir.
Any pain assessment tool based on which you can start these pain medicines?
Yes, a pain assessment tools like NRS scoring system is NRS tool is there, numeric rating scale from 0 to 10, in which we can rate the pains, and then according to that we can give. For opioids, it is more than 7 to 8. If the NRS is more than 7 to 8, we can give opioids.
Visual assessment scale also
Yes,
is there.
scale. Yes.
Okay, so these are your initial blood picture. Just can you just mention the abnormal ones from here, just for
One is
the
WBC count of 17,000, platelet 1,40,000, and then serum amylase 766 and lipase 5,048, TSH of 14.3, and HS tropi 259, and triglycerides 287. Serum
procalcitonin?
creatinine 2. There is raised serum creatinine and uric acid as well.
Anything about procalcitonin? Is it normal?
Yes, sir. Procalcitonin is also elevated.
So these are X-ray. So anything you want to comment on this X-ray?
So X-ray is suggestive of pleural effusion, and there is
How can you see effusion in X-ray in this patient?
so there is a CP angle blunting in the left side.
Okay, slightly. Okay,
So
anything else?
other than that, so the X-ray is suggestive of no sir.
Any
From
comment
this
on the
X-ray,
bowel from here? Can you comment anything on the bowel loops?
yes sir, in bowel loops are distended.
So is there any feature of perforation or obstruction here?
Uh, Perforation is not there, sir, as there is no gas in the fundus, free gas in the fundus, and obstruction for
Free gas in the
obstruction.
fundus is a feature of free gas in the fundus is of stomach origin, isn't it? Free gas
Okay,
under the diaphragm.
free gas under the diaphragm. So obstruction we cannot rule out from this X-ray.
Okay, fine. So this is the ultrasound picture, though in your exam probably it won't be asked, but just to show you, this is the ultrasound picture. Okay. Can you comment on the pancreas here?
Pancreas looks bulky,
Hmm.
and there is a fluid collection around the pancreas.
So based on this initial investigation reports, how can you narrow down the differentials?
So, according to initial investigation reports, as the amylase and lipase are raised, and more than 3 times they are raised, so we can think of pancreatitis. Other than that,
Initial presentation, and now also you are telling these three only.
so to
Amylase
narrow these levels, other is the radiological investigation like USG report, and third is this acute pain abdomen. So any two of the three will suggest acute pancreatitis.
So among this amylase and lipase, which one is more specific?
Lipase is more specific.
Okay, what are the other conditions where amylase can also be high?
So amylase can be high in other GI conditions like GI perforation, obstruction, in abdominal trauma, in salivary gland, in trauma, tumors. All these cases, amylase will
Any
be
other
elevated.
medical cases?
Sorry, sir.
Any medical case where amylase can also be high? Like DK also it can be high, no?
Oh, yes, sir.
Okay, so most probably we are dealing with a case of acute pancreatitis in day 2, day 3. So how do you classify severity of acute pancreatitis?
So to classify severity of acute pancreatitis, there is a revised Atlanta classification, which is classified as mild, moderate, and severe. In mild, there is no organ failure and no local uh, complications. But in moderate, there is transient organ failure and local or systemic complication, which resolves within 48 hours. But in severe, the organ failure persists more than 48 hours with systemic complications.
What are the systemic complications here?
In pancreatitis, systemic complications could be ascites, a pleural effusion, ARDS, and
And
it
what are
could
the
be
three? How do you classify the systemic complications? What scoring system do you use here for acute pancreatitis?
for acute pancreatitis, or for organ failure, we use the Marshall classification, where
Yes.
renal, respiratory, and cardiac system are assessed on the basis of PF ratio, serum creatinine, and systolic blood pressure. And if the score is more than 2, then organ failure is considered.
Okay. Uh, So what are the common causes of acute pancreatitis?
Some common causes include GB stone, alcohol. Uh, it could be hypercalcemia, hypertriglyceridemia, drug-induced post-ERCP pancreatitis, or idiopathic.
What are the drug induced? What are the drugs?
Drugs like sulfonamides, thiazides, diuretics, steroids, estrogen, these can cause pancreatitis.
Antibiotics.
In antibiotics, in antibiotics, I don't remember at present.
How to do the fluid resuscitation in acute pancreatitis? You have, you will prefer colloids or crystalloids?
So crystalloids,
Okay.
isotonic crystalloid.
Okay. So how much fluid to give? How do you determine that?
So initially in pancreatitis, we go for fluid resuscitation at the rate of around 150 to 300 ml per hour. And we reassess the need for fluid every 6 hours according to the volume status and patient's clinical condition. And then accordingly, we titrate the fluid, and maximum up to 24 to 48 hours resuscitation is needed in pancreatitis patients.
So, in your patient, how will you assess this fluid responsiveness or fluid tolerance?
So after 6 hours, I will assess for the heart rate and the blood pressure and the patient's clinical condition and uh, her lungs condition. If there is any overload signs, we can do
So your patient is
lungs
already,
ultrasound.
you have told that you have this patient is already having pleural effusion, right?
Yes, sir.
Probably a mild ARDS also probably there is present because in the ABG also you can see the PO2 is 55.
50.
Hmm. So, I mean, will there be the same fluid rate you will continue 150 to 300 ml, or how will you determine how to give fluids?
So initially I'll go with yes 150 ml per hour, and then I will determine by using the lung ultrasound focused bedside if there is any worsening in the lung fluid, or we can see the IVC. Though IVC is not a very good indicator in spontaneously breathing patients, but that way we can assess the fluid responsiveness and all. And other than that, we can monitor the heart rate and blood pressure.
Any other dynamic test do you know of which can be done in spontaneously breathing patients for fluid
So,
responsiveness? Have you heard of passive levetizing test?
yes, the passive leg rest test.
So will it be very much valid here? I mean, what is it? Can you just
Yes, sir, we can do passive leg raise test here.
okay? Okay, I'll come to that later on. Okay. So how will you manage abdominal pain in this patient?
So for abdominal pain, I will start with the analgesics, paracetamol and opioids can be given in form of tramadol or injection fentanyl. And other than that, epidural analgesia can also be used as per the EpiPen trial to
Mhm.
control the pain.
Any contraindication for giving opioids, or you can use opioids straight away?
Sir, as per latest studies, there is no contraindications for opioids.
Okay, right. Okay. So this is the CT scan. It's a thoracic cut. Thoracic cut of this patient. What does it show?
So there is bilateral effusion, pleural effusion.
Do you can you comment on pleural effusion from this cut, or you need to see any other CT cuts? From this view, this is a parenchymal view, you can comment, or you need to check from other views as well.
So we
This can
can check. So we can check from other views also, and we can comment from this also.
okay because consolidation also will look white, no?
Yes, a consolidation can be there.
It can be basal consolidation as well.
Yes, sir.
And along with basal constellation, along with pleural fluid also. So anything, any other model, any other window you want to see, or
Oh,
I just request the other participants who are watching this case history and this demo, kindly don't write anything right now in the chat box. Okay. So it can distract the examinee. So we'll discuss all these things after in the debriefing session. Okay. Okay.
sorry, sir, I don't remember.
No issue. No issue. Okay. So this is the CT abdomen. This is the CT abdomen. Can you describe the CT abdomen?
In this CT abdomen section shows the
This is a contrast CT or non-contrast CT?
so this is a non-contrast CT, sir.
Okay, so non-contrast CT abdomen. So why do you think the non-contrast CT abdomen was done in this patient?
So after USG, if the patient's condition is not resolving and still there is symptoms, then we can go for CT scan in 48 to 72 hours to rule out the cause.
I'm asking you why non-contrast CT scan was done. Which one is better for detecting the pancreatitis and its complications? Contrast CT scan or non-contrast?
Contrast CT scan is better, sir, for
What may be
dealing
the
with
reason
the
in this patient?
complications.
What may be the reason in this
The
patient?
patient's creatinine was high, so non-contrast CT could have been done.
So you are telling that there was increased risk of contrast-induced
Induced
nephropathy.
nephropathy. Yes, sir.
So how can you minimize the risk of contrast-induced nephropathy in critical ill patients?
So to minimize, one is we can use the ISO or smaller contrast agents. Second is we can give the contrast according to the weight of the patient, so that not more doses will go. And third is we can give IV fluids to prevent the further contrast induced damage to the tubules. And
Okay.
fourth one is we can use N-acetylcysteine for
In
during.
acetylcysteine, I mean, how much dose?
So oral dose is 600 mg. For 24 to 48 hours we can
Are you
use.
sure?
Sorry, sir.
Are you sure about this dosing for dosing of NSC?
Yes, sir. Oral dose 600 mg.
Okay. Yeah, it's 1200 milligram twice daily. Okay. And started 12 hours before the starting of the procedure and continued after, I mean, continued 48 hours after the procedure. But does the recent study show any benefit of NAC?
No, sir. There is no benefit of NAC as per studies.
Any benefit of doing hemodialysis for preventing CIN?
No, there is no benefit of doing dialysis in CIN, as in normal patients after 3 to 7 days, the creatinine renal function comes to baseline. So there is no recommendation to go for RRT for CIN.
Yeah. And anything related to soda bicarb?
Soda bicarb also, sir, have been used but has shown no benefit.
So in this CT, the plain CT, anything commendable from that plain CT?
So there is a localized collection could be seen around the pancreas in the plain CT.
So in the plain CT, okay. There was not too much of localized collection. Okay, this CT scan, this contrast CT scan was done after like 10 days. Okay, again for this patient. Can you describe this CT scan?
In this, sir, initially there is a large collection around pancreas,
Hmm.
and in the different cut, it is the collection is increasing in size.
Okay. Hey, this is a large collection, peripancreatic collection can be
Very
seen. And what is the pancreatic tissue?
So pancreatic tissue in the first CT, there is a just below the collection.
Here it is visible, but here
Yes.
it is not visible. Okay. Anything comment? Any comments on the spleen?
The spleen has been so displaced. Not much.
Coming to the question. Okay. So how to determine the severity of the acute pancreatitis in CT scan?
So in CT scan, we have CT severity index to determine the severity. One is according to the inflammation and one is according to the necrosis. So in inflammation, there is no inflammation, then there is peripancreatic inflammation, then one collection, and then more than two uh, collections around the pancreas. And in necrosis, there is grading according to no necrosis, then necrosis less than 30%, and necrosis more than 30%.
Okay. What is this classification known as?
CT severity index for pancreatitis. Bell's is
Uh,
at
Modified Balthazar scoring and then modified CT severity index. Okay. So what are the other diagnostic imaging commonly performed with acute pancreatitis? And what are the indications for them? One is ultrasound we have seen. One is CT. Any other diagnostic imaging?
yes, MRI can be done
Mhm.
to rule out to look for any choledocholithiasis or extent of collections and everything. MRI can be done.
Any advantage of MRI in contrast to CECT?
So just to look for the smaller size stones and to differentiate, yes, sir, to differentiate between pseudocyst and necrotizing.
What dye is used in MRI? MRCP. Any dye is used?
Gadolinium is in MRI.
No, for pancreatitis, you do MRCP. Any dye is used for that?
I don't know.
Okay, okay. So, what are the different types of peripancreatic fluid collections are classified?
Peripancreatic fluid collections could be acute necrotic collections or which after fault of a necrosis, and it could be peripancreatic collection which becomes a pseudocyst of pancreas, and other than pancreatic collections.
Necrotic collections. Okay. So, how will nutritional status in acute pancreatitis and how to start nutrition in a case of severe acute pancreatitis?
So in acute pancreatitis, as the patient will have a vomiting and nausea, so the nutritional status will be poor generally, and they will not be able to take the oral diet. If mild pancreatitis, we can start with oral diet if patient is able to take immediately, and if it is not possible, then we can start with an enteral nutrition with a nasogastric or nasovaginal Riles tube within 24
For
48
severe
hours.
acute pancreatitis?
For severe acute pancreatitis, also we can start uh, as early as 24 to 48 hours. And if in case the nutritional requirement has not been achieved to maximum, we can wait for 7 days. Then we can start with total
Okay.
parenteral
So,
nutrition.
how to choose nasogastric versus nasojejunal feeding in pancreatitis?
As per studies, there is not much difference in nasovaginal versus nasogastric feeding. But the patients who are having more vomiting and intolerance to the diet, we can try nasovaginal feed in those patients.
And administering TPN, you have already told. Okay. So what are the just to ask you, what are the benefits of enteral nutrition over total parenteral nutrition in pancreatitis?
So enteral nutrition helps in gut motility and reduces the risk of infection as compared to total parenteral nutrition.
And
Enteral nutrition is a natural of sorry, not getting the word.
no issues.
Uh,
So, in your patient, there was pleural effusion. So, what are the cause of pleural effusion in acute pancreatitis?
So one could be because of the third spacing. Pleural effusion can be there because of inflammation. The other could be due to fluid resuscitation. There could be pleural effusion. And yes, sir.
No, okay. So, in during telling the severity of acute pancreatitis, you haven't told about anything like any criteria or any scoring systems other than modified Atlanta scoring system regarding how to determine severity. So, any scoring system you
One
know?
is Ranson's scoring system. One is bicep scoring system. And then
What
Glasgow
is the
invariant.
bicep scoring system?
So bicep scoring system is one BUN more than 25. Then impaired mental
Just give me the
status.
components. Don't give me the values. Just tell me the components.
Uh, okay, so one impaired mental status and SIRS and age and pleural effusion. More than three is considered severe pancreatitis.
So, how will you manage pleural effusion for this patient?
For this patient, sir, we can give NIV, non-invasive ventilation, as it is more likely transudative pleural effusion. So we can use a non-invasive ventilation with positive pressures, and if needed, we can use diuretics to reduce pleural effusion.
Any role of HFNC?
So HFNC won't give a much PEEP in this condition, so it won't be much helpful in this patient.
Will you tap it?
If the patient is not symptomatic, so there is no need to tap. It will resolve as the disease
Your
will
patient is
improve.
having tachycardia, tachypnea, was having
Yes.
pleural effusion. So that's why I'm asking. Will you tap this in?
No, sir. I will not tap this pleural
Okay.
effusion.
So any role of monitoring intra-abdominal pressure in severe acute pancreatitis?
Yes, sir. There is very high risk of raising intra-abdominal pressures in pancreatitis, as there is ascites because of inflammation. Other than that, fluid resuscitation might worsen the abdominal compartment pressures. So it is very
You
important.
monitor IAP in your patient?
So for IAP measurements, we can use the intravesical method to monitor the intra-abdominal pressure.
Any other method do you know of?
So we can use esophageal. Sorry, sir, I don't know.
Okay, fine. So, how to suspect necrotizing acute pancreatitis in this patient? Because initially we have done only plain CT, isn't it? So, how to suspect necrotizing acute pancreatitis?
So there can be worsening symptoms of the patient, and
Will
there
you
could
give
be fever.
will you give antibiotics for this necrotizing acute pancreatitis?
Yes, sir, we will give antibiotics for necrotizing acute pancreatitis.
Are you
As
sure?
sir,
What is the antibiotic policy? When will you administer antibiotics in acute
so there
pancreatitis?
is no role of prophylactic antibiotic in acute pancreatitis as per the guideline. But sir, if there is a risk of infection in the patient, so then we can give antibiotics.
Okay. What are the indications for surgical management of the patient?
So if there is a peripancreatic collection and patient is symptomatic and fever is not resolving, then we can go for surgical management.
ERCP, what are the indications for emergent ERCP? Not in your patient, but in general.
So if there is a gall stone or obstruction of CVD, then emergent ERCP is necessary uh, in acute
Uh,
pancreatitis within
okay,
48
so
hours maximum.
which mode of surgical procedures are preferable, percutaneous or open surgical?
So percutaneous is the preferred mode, and if not possible with the percutaneous drainage, then endoscopic drainage can be tried.
What is the preferred timing for percutaneous or surgical procedures?
So for surgical percutaneous, we can for surgical sir, at least we have to wait for 4 weeks, and we
Percutaneous?
can for percutaneous according to the symptoms and the collection we can do the percutaneous drainage.
So what are the other measures in general will you take in your patient?
So other measures would be
Like you have
fluid.
taken care of the pain, antibiotic policy, fluids, nutrition, and what other oxygen support and all these things. What are the other measures will you take?
So other measures like thromboprophylaxis and
So how will you give thromboprophylaxis in this patient?
I'll start with
Pharmacological or mechanical? Which one is preferred?
pharmacological is preferred if there is no contraindication. So as creatinine is high, we can start with fragmin as thromboprophylaxis.
Don't use any brand name. Okay, if you want to use, you can use like dalteparin. Don't use
Okay,
any brand.
okay,
Okay.
sir.
Any role of exercise, physical exercise, physiotherapy, and all?
Yes,
You
sir.
can.
Physiotherapy is beneficial.
So, how will you counsel regarding this patient to her parents?
So as the patient is having acute pancreatitis, I will inform the family that it is pancreatitis and it takes a long course, and the patient might be needed to stay in the hospital for at least a month, and needs some regular monitoring and observation. And
Anything regarding the prognosis, regarding the mortality risk?
so initially, I will explain about the disease severity and the further plan, and with later course of the action, we
They
can
are
explain.
attendants are asking how this has occurred in their child.
So I can attribute the cause to be either some drug which she was taking for weight loss, or it could be due to some viral infection that might have triggered this pancreatitis.
And they are also asking whether she will be needing any surgery or not for this thing. Because
Surgery could be needed in the.
gastroenterologist has told them she may require surgery in near future.
Yes, sir. I will explain about the chances of surgery in future.
Okay, okay, Dr. Shweta, thank you very much. I think we can end here.
Okay, sir. Thank you, sir.
Sir,
Okay, Shubhankar,
hmm.
I have Dr. Paras Jain with me. I've asked him to, he's my colleague. Let me introduce. He's the additional director here in Reliance Foundation. And he had been a consultant for more than a decade in Australia. He just came back and joined us. So he had been analyzing the answers itself. I think you
Hmm.
can discuss the answers, and Dr. Paras will chip in whenever it is needed. Very quickly, you discuss the answers. I will also be there. And all the guys who were bubbling with all your energy to
Yes,
put
they can
some
answer
comments
now.
and others, you
I'll,
can put
I'll,
some
I'll
comments or
invite
raise
answers
your
from them.
hands to ask questions. Shubhankar, you start to give the
Yes, yes.
answers.
Just 1 minute, sir.
Praveen, quickly, you can ask the question.
How
before
much time do I have, sir, for this answer discussion?
10, 12 minutes for the discussion.
Okay, it's visible, no, sir?
Yes, yes.
So clearly, we are dealing with a case of like acute pancreatitis, probably severe acute pancreatitis. Okay, so during
Also analyze her response too. Are we happy with the case
uh,
presentation?
I think we can.
I think she
No,
spoke acute abdomen.
Quite early. Well, yeah.
Okay. So
The 78. I like if she could have pointed it out, I have asked her. I would have asked her whether you will give calcium supplementation in this patient in the emergency itself. The answer would have been no. Anyway, he couldn't pick it up. Fluid resuscitation she has told, but she couldn't. Also, you have to in fluid resuscitation. You cannot say like 150 to 300 ml for all the patients. You have to tell about the dynamic parameters for monitoring the fluid responsiveness and also fluid tolerance. IVC most of the time will not be very reliable in this type of patient. You can do PLRT, you can do LVOT, VTI measurement, and all these things you can do. And also you have to check the fluid tolerance, like B lines, pleural effusion, how much is the IAP, and all these things. Based on this, you can and the clinical monitoring, obviously, urine output and ABG, lactation, and all these things. Or based on all these things, you have to balance it out through a strategy. And okay.
anything you want to comment?
No, I think.
Okay. Diagnosis of acute pancreatitis, she has told already. She classify the severity. Only thing I want to tell that modified Atlanta classification we have to tell, but also the clinical other scoring systems. At least you like Ransom scoring and other bicep scoring you have to tell. Other than the scoring systems like CRP itself, after CRP within 72 hours itself can have a poor Apache 2 scoring, very high Apache 2 scoring. These scorings are also to be mentioned for determining the severity of the acute pancreatitis. Common causes, as you have told, but drug-induced, the drugs for acute pancreatitis will be a question in the exam. So we have to at least a bit like antibiotics, anticonvulsants, diuretics. She has told some mentioning of those should be there. Okay, fluid resuscitation, crystalloids are obviously preferable. I would have asked regarding albumin, but she couldn't tell here. So albumin, whether we have to use albumin, we can use albumin if the patient albumin is very low, like 2 here. Whether we should have used or not. The answer will be no, because even in the severe acute pancreatitis, the albumin supplementation has shown to be poorer outcome. And if you mention about albumin anything here or any college, then the examiner will also ask you about other uses or the class 1 recommendations for using albumin in critical ill patients. A recent trial for fluid resuscitation in acute pancreatitis was the watershed trial, could be mentioned here. They'll not go into the details of it, but the main findings. Okay. How to manage the abdominal pain? She has told the modalities. Okay. First line paracetamol, second line opioids. Both tramadol and fentanyl can be used. Fentanyl continuous infusion. Relatively stable patient, fentanyl patch can be used. And even after giving all this, if the pain is not controlled, then we can use epidural anesthesia and also celiac ganglion block in extreme cases. Antibiotic policy for acute pancreatitis, obviously, I think she couldn't clarify here properly. The any for prophylactic use of antibiotics obviously not recommended. Second thing is that if you are suspecting extra pancreatic infection along with pancreatitis, so then if you are suspecting cholangitis here or other source of infection, maybe the patient is having UTI simultaneously, which was not revealed there. So you can use antibiotics. And for she has told that necrotizing pancreatitis, you will start with antibiotics. That is also a wrong answer. You will not start antibiotics straight away in the necrotizing pancreatitis. If you start there is infective necrosis, then only you will start. And you have to start the antibiotics which penetrates the pancreatic parenchyma very well, like carbapenems and quinolones, etc. And preferably, you have to avoid metronidazole because it is also considered as a cause of acute pancreatitis. Sir, anything here you because this antibiotic policy in acute pancreatitis is a very favorite question of the examiners.
No, no, it is quite appropriate. I think antibiotics should not be used. I think most of the time it could be just sterile necrosis,
Yes.
unless you are suspecting infected necrosis or there is a reasonable evidence of having a infection, or then in that situation you can start. Then only you should consider starting antibiotics. Otherwise,
General,
it could be just sterile necrosis
yes, sir.
that is driving cells response. Yeah.
Yes. So general, I mean, question here can be the procalcitonin was high. It was like 2, so will you start? So it is like 2 or 3 days of presentation. So initial the first 7 days, and if you are not suspecting any extra pancreatic infection, then we should not give any antibiotics. It's a clinical thumb rule for giving antibiotic in acute pancreatitis. So this was the CT. I have asked a bit because these questions like are more related to the day-to-day work in day-to-day bedside work. Like this is the lung window of the patient. So you need to comment from the mediastinal window where you can differentiate between the pleural effusion and the consolidation well. There you can sharply see the differentiation, sharply see the margin of pleural effusion and separated by the consolidation you can see there. So mediastinal window you need to see to confirm it whether it is only pleural effusion or effusion along with consolidation. Here you can also see some this air bronchogram here. So obviously there is a part of consolidation or basal atelectasis there. Okay, this was the plain CT abdomen. So initially, this non-contrast CT was performed because of 2 reasons. One was like AKI, in presence of AKI, which can be a major factor for precipitating CIN. And the second thing is the patient was extremely tachypnic, so maybe the breath holding for the MRI. I have asked her why MRI couldn't be performed in this patient. So MRI may not have been a good modality despite the patient have AKI because this patient was tachypnic, maybe breath holding capacity wouldn't be good at this point of time. So MRCP couldn't be done, and non-contrast abdomen was done. And this is the air that is this is a fundal gas shadow. This is not the peripancreatic fluid collection. Here we can see the pancreas is grossly swollen up. Yeah, and in this picture, this contrast enhanced CT scan, this pancreas was almost gone. There is hardly any pancreatic tissue was visible, and overall replaced with the necrotic material here. So the very high, very severe pancreatitis was there, necrotizing pancreatitis was there. And I also asked her regarding this comment about spleen, because some areas of spleen where we can see that there is hypo enhancing the contrast. So later on, we also found that this from the CT itself, there was a splenic artery thrombosis. These arterial thrombosis or splenic vein thrombosis. So this kind of thrombosis, intra-abdominal venous thrombosis, mesenteric venous thrombosis are very common in case of severe acute pancreatitis. So we have to also check for these things and keep these in mind. Okay, CT scan determine the severity of the CT scan. She has told modified Balthazar index and CT severity index. Other diagnostic imaging, ultrasound. Okay, straight X-ray abdomen could have been told. Straight X-ray abdomen sometimes in emergency gives us some amount of good information. Like initial X-ray also you have seen there was a bit of ileus, and sometimes the pancreatic stone can be visible in X-ray itself. Okay, and MRCP she has told MRCP versus ERCP could be a question here. When to perform ERCP, when to perform MRCP, and define peripancreatic fluid collections. You just see from the this thing from the guideline itself. It depends upon the duration. If it is less than 4 weeks and more than 4 weeks, and a sterile and necrotic, depend upon this. One is a peripancreatic necrotic collection and Waldorf necrosis, and peripancreatic fluid collection and pseudocyst. This is the classification. These are common and CTR questions. How will you assess nutritional status in acute pancreatitis? As she has presented like 2 to 3 days. So initially we can use some nutritional CVAT scoring system like NRS 22 scoring you can use. Others, these things in fact are recommended in. I have incorporated this question because this is this was incorporated in the SPAN guideline 2024 and also the AJC recommendation in 2024 that you should monitor, assess the initial nutritional status. And obviously, there is no controversy of starting nutrition as early as possible, even if it is a case of severe acute pancreatitis, and enteral nutrition is preferable. She has already told nasogastric versus nasojejunal. The general protocol is to start enteral nutrition, and if you look for the response, if there is if you think the abdomen is not too tight, IAP is not too high, and patient is not having that too much of symptoms like too much of feed or intolerance symptoms, like whenever you give feed, the patient is having pain or vomiting it out. All these things, if there is not that, you can continue the enteral feeding. Sometimes patients are too sick to take adequately through the enteral, so you can use NG, nasogastric. And if the patient is having really intolerance with NG and having significant gastroparesis, then you can put NJ and you can continue the enteral feeding. Obviously, enteral feeding are definitely better and superior to the TPN. There is no controversy regarding that. The causes are like she has told one or two points regarding why to start enteral feeding, and enteral feeding is better. Also, this enteral feeding this help to maintain the height of the villi and intestinal villi, so it prevents the villus atrophy, and also they are associated with related less incidence of bacterial translocation. So and thereby they prevent the infective rate in the acute pancreatitis and any and also prevent the uh, chance of mortality there. So mortality and morbidity is less with enteral nutrition rather than TPN in case of acute pancreatitis. Sir, this is also a very favorite question of examiners. Sir, any point you want to share here?
No, I think what you have mentioned is appropriate. I think there is a reasonable evidence for enteral nutrition, early enteral nutrition in acute severe pancreatitis. If NG or NJ, it doesn't matter, but NJ is established if there is not tolerating NG or there is a evidence of gastroparesis. And then initiation of a TPN if there is a unsuccessful attempt with the enteral nutrition, or if patient is multi-organ failure and not tolerating nasogastric or enteral nutrition can't be established, then in that situation, parenteral nutrition. Yeah.
Yes. Anything from the attendees? Anything they want further clarification, or till now whatever I am telling, it's okay for them, understandable.
No, they are actually to be. They have to express themselves on the chat box. I am continuously looking into it, so feel
Okay.
free to comment on there. Any questions, any comment, any criticism, anything. I am constantly looking into it so that I can respond. You carry on.
Okay. So pleural effusion, she has rightly mentioned a characteristic of pleural fluid. Obviously, the amylase level will be high. It can be transudative, it can be exudative as well. Obviously, initially we will not tap the pleural fluid, definitely pleural effusion in acute pancreatitis, because it's a reactive and mostly transudative. But if the patient is having severe respiratory distress due to massive pleural effusion, then sometimes we may have to tap it out. That would be the better answer. Role of monitoring IAP, I think she has mentioned regarding IAP quite well. There is nothing to discuss about IAP, and the severity classification is IAP already is known question. Necrosis, how to suspect and manage, because the patient initially we couldn't do a contrast CT scan, so non-contrast was performed. Now in these patients we have to monitor the patients daily, obviously, like ICU monitoring. Now, whenever the patient, particularly after 7 to 10 days, in the second week of the acute pancreatitis, whenever the patient starts deteriorating, they again re-onset of fever, CRP goes high, procalcitonin go high, and the patient deteriorates clinically with a toxic look and maybe reappearance of shock. Then, in this kind of scenario, we have to suspect that patient is probably developing severe necrotizing pancreatitis. And so to manage, the management is like mostly symptomatic and supportive. Also, previously they used to recommend a CT guided for FNAC for this kind of patient. Nowadays, they also straight away don't have to do CT guided FNAC for all the patients. Only for selective patients we can use. Necrosing severe acute pancreatitis, if we are suspecting again severe infective necrosis, then only you have to give the antibiotics and monitor accordingly.
I think FNAC, both me and Dr. Jain think that FNAC is more or less outdated. It's more of
Yes,
a
yes, yes.
clinical and uh, decision
Yeah.
along with your cultures and everything, with a deteriorating condition, with raised your TLCs, dysfunction and others. So you
Yes, yes.
decide to drain the necrosis itself, right? And
Mm.
the drain, I would say, most of the hospitals have now come up with a non sort of interventional option rather than open necrosectomy, which is again
Yes.
almost getting more and more obsolete itself. So the idea is now triple therapy sort of, that you do percutaneous drainage and the CT guided. The other approach is you go endoscopically through endo ultrasound. You
Mm.
identify, you can put a grommet. It's called Nagi stent, right? Dr. Nagi Reddy has come up. And then you can repeatedly do endoscopic guided drainage of the necrotic material through that stent itself, as well as the stent will allow necrotic material to drain into through the posterior wall into the stomach itself.
Yes,
And
yes.
rest of the things, if there is still remaining, then you can go retroperitoneally through retroperitoneoscope. So this is a three-way approach towards draining that entire pancreatic material itself, and it can evade the rare occurrence of a surgical necrosectomy, because particularly surgical necrosectomy, even if you do lab guided and others, the morbidity is too high. It is very difficult to close the abdomen itself. Then there are the issues of going recurrent. In lab, you have to again go through the recurrent different ports itself. In open, historically, I have done multiple cases on that. We didn't use to close. We used to put a zipper itself, and every alternate day going and open into and draining the necrotic material would be very cumbersome itself.
Yes. I think Sarah summarized the surgical options for acute pancreatitis quite well. And the timings are, they are told the timing should be preferably more than 4 weeks.
Timing,
Prefer
this is the only
Yeah.
way where
Mm.
you delay the source control, right?
Yes.
Only indication in an infective where you delay, because the
Mm.
demarcation between the necrotic and actual pancreas or the healthy pancreas, it takes time for the demarcation to happen. So the plain
Yes.
surgical
Falling off.
plane is difficult, or the thick material is also difficult. And at times, the other point of waiting is uh, that many a times, if you are too early, that you may drain out the healthy pancreas itself, and maybe the pancreas in the first second week may not be have been, the necrosis may not have been infected itself. So in
Mm.
fact, you may be introducing infection by doing a drainage itself. So
Yes,
that
yes.
becomes a little tricky part.
Also, sir, with the drain, there may be peri-drain seepage of the pancreatic juice coming
So
out. And it can
obviously, the
uh,
fistula, use,
yes,
then
yes.
injury, drains are not completely innocuous. They can hit. There is a very vascular day. The pancreatic bed is quite vascular itself. The bleeding risk is also there. So a lot of way. So we have to. It's a very both art and science to decide the particular timing itself. But obviously, we would like to defer a bit rather than or doing it hurriedly.
Regarding ERCP also the latest guidance, they say that if the pancreatitis is associated with, you are suspecting that is severe associated with acute cholangitis, then early ERCP within first 24 hours definitely decreases the mortality and morbidity. But if there is biliary pancreatitis but not associated with acute cholangitis, then diagnostic ERCP should be avoided, and you have to first do an MRCP or EUS to rule out the CBD stone and all these things. Only if it is associated with acute cholangitis, then only you go for early ERCP within first 24 hours.
That
What
too
other?
also at times people have different opinions, particularly post ERCP. If the pain has already started and you
Hmm.
do an ERCP, there could be edema of that sphincter itself, and that might sort of aggravate the situation. So in this way, where you do not have a very clear answer, my suggestion for the candidates is that you put it as a uh, sort of a balanced view that that this is a situation where people are doing it within the first 24 hours, keeping in mind that there could be a possibility of aggravation of due to the sphincter edema itself. So we have to assess. So always give your answer in that way. In real life also,
That is
this is
dilemma. Yeah.
there is always a clinical dilemma. So we have to individualize. That's why because this is a postdoctoral exams, right? You
Yes.
have to justify your answer, but also you have certain points that you mention that there cannot be a very clear answer to it. I am considering the other factors too. So that's how you justify both, right? That you have a complete knowledge. You are sending a
Yes.
signal to the examiner that I am aware of the risk and benefits, and I am
Yes.
sort of considering both the facts, and I'm putting it to you.
I have taken a broad view.
Broad view.
Other supportive measures, I think she has mentioned, and like all these things, apart from the things we have discussed, like physiotherapy, incentives, spirometry, and the active and passive physiotherapy, they can ask when to start. If the time permits, they can ask when to start the active physiotherapy, when to start the passive physiotherapy, what are the lung exercises, and all these things. Now, sir, counseling, sir.
Counseling, I think the context is the is the complexity of the situation, then overall a prolonged I would discuss that this is a prolonged situation with indefinite period of treatment and also uncertain prognosis. And then we have to give an environment where we will discuss and all others, whom we will discuss the next of kin and all stuff. These are the common principles of communication itself. And component is mostly the clinical, if there are any interventions itself, financial, infection control, long-term prognosis, morbidity of an acute, severe acute pancreatitis itself. So all these points should be included in it, mentioned in it, and also uh, uh, we will ask any questions, specific questions from the next of kin itself. This is more or less counseling component in this say. Shubhankar, a lot of questions NNA. Very quickly, let us uh, we discussed fluid management in detail, right? So it has pancreatitis has a bimodal distribution of death or deterioration. The first week is mostly organ perfusion related.
Yeah.
If you perfuse too much, that of the ARDS and lung deterioration. If you do less, so the kidneys are going to be fried up. So fluid management, obviously, it's a very, very important, and organ support in the first week is a very important. The other important things that you need to very brush up quickly is the severity assessment, which patients need the ICU admissions and others, and how you are going to give an organ support itself, right? Then the second week are mostly on the antibiotics and nutrition. A lot of questions
Yes.
on the nutrition. Early enteral we have emphasized. Just quickly read because there are a lot of little bit of differences about the American, European, Canadian sort of a.
Right.
So early enteral, NJ if not possible, early enteral not possible, and parenteral nutrition if you are not being able to achieve in 5 to 7 days time. Partial parenteral or supplemental parenteral nutrition, not very clear, but practically can be achieved, right? But not very advantageous also. It's an if you are if the patient tolerates enteral, I think they can tolerate
In the second half, especially when patient is stabilizing, getting better, then you can, while weaning the TPN, you can use the partial PN at
okay.
that time.
While weaning PN.
Yes.
I agree with you. And there is also not semi-essential, we call it elemental, or that means your peptides, polypeptides and oligosaccharides. That means partially digested. We always try start with that. It's also commercially available, no source peptides and all others. Regarding necrosis, infected necrosis diagnosis, I forgot the CT scan points. You would be definitely asked about the CT if there is a good CT in the A. all the city severity index and all others. And lastly, read about, you can speak to your intervention radiologist or your gastroenterologist about the updates of what they are doing actually itself, that how to drain the necrosectomy and all others. And one more thing is the chronic complications or the later complication, not chronic, later and chronic complications of pancreatitis itself, particularly life-threatening bleeds like pseudoaneurysms of gastroduodenal artery or hepatic artery, then your infected pseudocyst, then there will be splenic thrombosis, splenic vein thrombosis with the autosplenectomy sort of a. So a lot of these complications you need to know, because one segment can be asked, or theoretically they can drag into this.
Yes.
Okay, so I think, and regarding and coverage of the antibiotics has to be, because if you are using it in the second, third day, what happens is there is a colonization of the GI tract, and then there is a translocation of bacteria. So the infection of infected necrosis comes from the from itself, from the patient itself, very seldom from the outside itself. So colonization of your that unit's bacteria, right? And according to the this antibiogram of that particular unit, you have to choose, of the hospital you have to choose itself. Okay, so but obviously the certain carbapenems have a better penetration. Both, I think it's not specific for Cilistatin imipenem.
Both
Imipenem has also got a name. They might ask you about the dosage itself, then whether an infusion or sort of a we might see standard things, sort of a. Cholecystectomy role in gallstone pancreatitis, once it is set in.
Gallstone pancreatitis, probably there is a role of cholecystectomy.
But what timing? What timing?
Sir, they have told that if there is mild gallstone acute pancreatitis, mild, then before discharge you have to do the cholecystectomy. Otherwise, if it's a severe case one, then after settling
You are
everything.
very unlikely. I have in a severe acute pancreatitis
No,
with organ
not possible.
dysfunction, with ventilation, dialysis, and all stuff.
Not
I
possible.
don't think practically anyone is going to do a cholecystectomy itself.
But
And
mild, they have written the guideline also, mild acute pancreatitis for gallstone pancreatitis. Then before discharge, they should undergo cholecystectomy.
Dr. Joshna Sahu, we have covered detailed pancreatitis in our success T theory
Theoretic.
itself, and
Yes.
we have given you the theory itself. So
One
I
of them is
request,
asking, yeah, T-pain, how to send T-pain components and all these things. I mean, examine in the long case, they will not drag into T-pain details of T-pain until and unless you drag yourself there. So we will discuss T-pain in our table viva. Target of fluid resuscitation. How can we do PLR in our ICU bed?
okay, so let's move to the next one. Otherwise, we won't be able to. So do we do a short case quickly? Is the short case person ready?
Sir, I am
Wait.
ready.
No, Vidur is doing the long case here, sir.
Bidur is
yes.
doing the long case.
Hmm.
Any short case person ready? Okay, Bidur, you have
Yes.
been waiting, so go ahead. You take the
Just one thing, 1 minute. Sir, overall, I think whatever she has told, in general, it is sufficient, more or less sufficient to get her 50% marks in the practical.
Yes.
What do you think, sir?
Now, I don't think we should. We are analyzing any individual performance.
No, individual
I'm
performance, but
thankful to
overall,
Shweta. Look it into the mock test
Mock test.
itself. In demo, we are not judging anyone.
Right.
Rather, I'm thankful. Well done, Shweta, to come. Candidate.
Dr. Ashwini. Dr. Ashwini, I think.
Yes, Dr. Ashwini.
Camera, or you want to be
Actually, we
anonymous?
choose to switch off the camera.
Sir, I'll be off camera.
Off camera. Okay, fair enough. Why people are so camera shy? Fair enough. I said that we don't want to be judgmental.
Yes.
And we support your decision, whatever you wish to. Vidur, you have to be camera friendly. No option for the examiners itself, demo examiners. Vidur, we are not being able to hear you. Huh?
Hello.
Hi, yeah,
Hello.
now, yeah, we can hear you.
Sir, is my screen shared?
No, no screen share, neither your video is on.
Video time on now.
Hmm.
Okay. सुदेशना मैम
बोलिए सर।
अब ये शेयर हुआ क्या?
अब शेयर हुआ है।
चलिए,
अभी आप
good.
फुल स्क्रीन कर दीजिए प्लीज सर। टॉप
Prajakta,
टॉप लेफ्ट
Top
आप एनेबल
left,
एडिटिंग
okay.
करके रखो, वो इतना इजी रहेगा।
ओके, मेरे इनेबल एडिटिंग कर दिया।
और फुल स्क्रीन करना पड़ेगा सर। लेफ्ट हैंड साइड टॉप कॉर्नर। हाँ, उसके बाद वाला राइट 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 की तरफ जाइए। राइट 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 उसके बाद हाँ दिस वन।
टेक्निकली बहुत साउंड है अपन। Okay. Who is presenting the case? Hello.
Ashwini is presenting the case. Just wait a second.
Yeah.
Ashwini, we are waiting for you.
I have to share my screen.
No, ma'am. You just have to answer the questions.
Okay. So, but I'm on the long case, right?
Yes, it is
The
long.
SH
It is long
case.
case one. We have got the
Okay, no issues.
cases, it is same.
I have got a different case history. That's it. Okay. No issues, ma'am. 50-year-old lady, known case of diabetes, presented with the sudden onset of severe headache, giddiness, altered sensorium since 4 hours. On examination, she has a GCS score of E2, V3, M6. Other systems are within normal range. Heart rate is 50. Blood pressure is 160/90. So the question is, what preliminary investigation and management would you do? What are the differentials?
Yeah. So you have a known diabetic. Yes,
So
Dr.
she is
Ashwini.
a known case of diabetes. Now she presented with the severe headache, giddiness, altered sensorium since 4 days. Her GCS score is total E2, V3, M6. That is 6, 9, 11. Now from heart rate and blood pressure, we can see she is hypertensive and bradycardic. So since there is a history of headache and altered mental sensorium, I'll go for the CT first.
What is the first investigation that you'll do? This patient has come in the ER. You are handling the ER.
Yes. If she is coming into the ER, I'll go systematic. Like I'll first manage her airway, breathing, circulation. Since her GCS score is E2, V3, E2, V2, E2, V3, and M6. I'll not think of intubating this patient, but then next is I will secure the IV cannula for her, and I'll take the basic investigations like ECG, ABG. Along with that, all the relevant hematological investigation I would like to send.
Okay.
A complete blood count,
Diabetic.
a renal function test, liver function test, and then I'll go for the radiological investigation, that is CT.
Okay. So, without the CT, you have ordered the CT, the patient will go. What are your differentials?
So from history, my differentials are, since she is a diabetic, now she present with altered mental status. Could be altered mental status, giddiness, headache, could be DK. So I would like to know her sugar levels. Headache, since headache
You
and
will
altered
measure
mental,
it. You will measure it
so
only.
yes, I'll measure it. Now there is history of headache plus altered mental status since 4 hours. We can suspect the IC bleed because the blood pressure is also high on the higher side. So could be the some intracranial bleed or subarachnoid hemorrhage might be there.
Okay. How will you differentiate, or rather, how will you investigate this case further? So you'll go for a CT scan. You will do routine investigations. You'll do sugars. You'll do ECG, ABG, right?
ECG, ABG I'll do.
So ECG is this.
So this ECG is suggestive of the T wave inversion from in V4, V5, V6. So that is suggestive of the raised intracranial pressure, or could be myocardial infarction. So I'd like to go for the cardiac biomarkers like troponin, proBNP. Like more relevant in this case will
Does your
be
patient
troponin.
have any historical history which suggests that the patient is going towards MI?
No, not means the history wise there is no chest pain. So MI will be less probable in this case.
Can MI present without chest pain in a diabetic?
MI can present without a typical presentation of MI in female and diabetic patient can be there.
Okay, move forward. So
So for that,
this is the
I need to examine her neurologically. Any focal deficit is there or not, or anything.
she was moving all four limbs, and she doesn't have any as such focal neural deficit.
Any history of vomiting is there or not? That I would like to ask.
No
And
history of
since
vomiting.
there is only history of headache, means how intense is that headache, so that I can understand the gravity of
She
the.
was alone. We are not able to get it. How severe was it?
How severe was
Okay,
it? Okay, she was
so the
alone there.
CT scan.
Okay.
So the CT scan now.
So
You went to the CT scan.
so
Describe
any
the
history of
CT.
fever? So this CT is suggestive of the diffuse bleeding, which was suggestive of the SS subarachnoid hemorrhage.
Now the drop has come 3. You had sent,
Troponin
no?
is 3. So yes. So troponin is 3. So this T wave inversion, and from the history wise, since she is complaining of headache, altered mental status, her blood pressure was high, she was bradycardic. Then this T wave troponin is negative. That means this T wave inversion can be explained by the non-cardiac pathology, like raised intracranial pressure.
Okay. Would you like to add anything regarding the CT? Anything else?
So
Okay. This is the CT. What is the next step? Hello. Hello.
question, sir. I was listening. Sir. Yes, sir. The net connection was on for the something. Yes,
So
sir.
we went for ECG, inversion, sugars normal, other reports normal, and the CT was suggestive of SH diffuse. That is what you're telling. And now, what is the next step in imaging or management?
So the next step for GCS is 11 at this time.
Yeah.
So I would first I'll immediately, since it is SH in medication wise, I immediately start with her on nimodipine to prevent the vasospasm, I'll grade the patient according to Hunt test scale, CT severity index, and then I'll involve the neurosurgeon for definitive management. For blood pressure, I'll
Would you
start
like to
some.
go for any angiography or any other modality along with NCCT?
Yes, sir. For angio, to look out the etiology of this SH, whether any aneurysm is there or not.
Okay. Suppose TROP was negative. Suppose this is a strong suspicion of SH where the patient has told or the patient's relative has told that the patient had recurrent headaches and this time it was very severe and TROP is negative and now you're almost confirmed that this could be SH. And still you have a negative CT. How do you proceed?
Still, I have negative CT, but if the clinical history is strong, I'll go for lumbar puncture.
So the patient is presented only in the first 4 hours. Patient's headache is since 4 hours. Do you expect lumbar puncture to give you anything?
No, means in first 4 hours, the sensitivity of the CT is highest than the lumbar puncture.
But CT was negative, so now you're told LP. So do I go for LP? Do I go for MRI? Do I go for anything else? Okay, leave it. When is lumbar puncture in SH considered negative or positive?
When it is considered as positive when there is a xanthochromia is there.
What is xanthochromia?
It is xanthochromia refers to the yellowish discoloration of the CSF fluid, which happened because of the lysis of the RBC.
Okay. Any specific numbers in relation to RBCs found in CSF after LP for an SH suspected patient? That these many RBCs are there, then it would be negative, or these many RBCs are there, then it would be considered positive?
Numbers are I don't remember.
Okay, fair enough. We move ahead. What are the different classifications of SH according to severity that you know?
Yes, sir. There is a Hunter classification, World Neurosurgeon Federation, then CT severity, then this CT classification, CT scan classification for the SH, then that's it. 3 classification.
Would you like to describe anyone?
So in Hunter's classification, grade 1 patient will be asymptomatic. Patient will complain of mild headache, but there won't be any neurological deficit. Grade 2 patient will complain of headache, but there won't be any neurological deficit won't be there, but there will be the involvement of the cranial nerve. Grade 3, the patient will complain of the moderate headache, and there will be focal neurological deficit. Grade 4, the patient will present with the severe headache, and there will be hemiplegia. Grade 5, the patient will present into the state of the coma.
Okay.
Then what federation neurology?
Which is the better classification, Hunt and Hess or WFNS?
Word federation classification is more reliable than Hunter's. So that is depend upon the GCS and neurological deficit.
Okay, what is the importance of CT-based classification?
CT-based classification is important.
Sorry, I couldn't listen to you. Sorry, can you repeat?
So CT classification is important in terms to predict the vasospasm, to predict the chances of the vasospasm.
That is good.
So if there
Okay.
is IVH is there, intraventricular involvement is there, and in the CT we can see thick rim, then that means the chances of vasospasm is more.
And what will that do to my patient?
So we can if we can predict this, the patient has high chance of means vasospasm. We can take the precaution early, or we can monitor for the vasospasm more frequently. Anyways, for to prevent vasospasm, we are going to start nimodipine early, means on day 1 only.
Okay. Coming back. So you had done, coming back to the same patient, you had done CT, there was diffuse SH. You talked to your neuro person, he told CT angio, you went for it. Now, what is the definitive treatment of aneurysmal SH? Suppose there was an aneurysm found out.
So for aneurysm, there are 2 treatment modalities, either coiling or clipping. So according to
Only
ISA
two are there?
trial, sorry.
Hello? Only two are
Yes, sir.
there? Okay. So again, move ahead.
So according to ISA trial, coiling is better than the clipping.
Always that is the case, or there are some cases where clipping is better?
So clipping is better if there is a wide neck aneurysm. This wide aneurysm is there. Then wide neck aneurysm is there. Then the clipping is better.
Wide neck aneurysm. Okay. Specific location where clipping is more preferred. Okay, moving ahead. What are the early and what are the different complications of SH which you would like to enumerate?
So rebleeding, which can be the early complication. Then vasospasm. There could be hyponatremia. Then obstructive hydrocephalus.
And what are the delayed complications?
So delayed is rebleeding is early. Vasospasm can be the delayed complication. Seizure.
Can vasospasm occur early or not?
So no, so vasospasm can occur early as well as, delayed seizure can be the delayed complications.
Hydrocaph can occur as a delayed complication or only early?
Hydrocap can, no sir, can it can be can occur as delayed complication.
Okay, so your neuro person and interventional person have told that they are coming and going to secure the aneurysm in the next 2 hours. How can you decrease the risk of rebleed, or what are the other management aspects that you would like to take care of as an intensivist?
So for reducing rebleed, the first I'll manage the blood pressure. I'll take care. The blood pressure should not go above systolic blood pressure. I'll try to maintain between 140 to 160. Should be less than 160. So for that, I'll start labetalol. It is 20 bolus. Then if it is BP is not controlled, I will increase the dose. Maximum dose that I can give is 200 mg.
What else except your blood pressure? Anything else? So the patient is in your ICU, you'll just take care of blood pressure.
No, sir. Overall, if patient is in my ICU, first I'll take care. First I'll go by airway. I'll monitor her GCS. If GCS is going, if she is
No,
if
GCS is
GCS
static.
is dropping,
GCS
I'll
is static.
so I'll go by airway breathing circulation. Airway I'll maintain. This oxygenation level I will maintain. Then blood pressure I'll manage. Then I'd like to take then temperature. I'll to prevent the secondary brain injury. I'll manage the temperature.
Have you heard of fast track beat?
Yes, sir. Feeding, yes, feeding, analgesia, thromboprophylaxis, then head elevation, ulcer prophylaxis, then any this spontaneous breeding trial, barbara rabbits, involving cactus. I'll check, or I'll. So
Okay,
among this, the feeding I'll take care.
so suppose this patient is in your ICU right now. Will you start any anti-epileptic at this point of time?
So there is no role of prophylactic antibiotic. Sir, what is the question, sir?
Okay,
Hello.
this patient is in our ICU. Will you go for any anti-epileptic initiation?
Huh. So there is no role of prophylactic anti-epileptic initiation. So if the patient is having evident seizure, then I'll start the anti-epileptics. Otherwise, no role of prophylactic anti.
Okay, okay. Suppose your patient had a GCS of E1, V2, and M3.
Even with
This patient had a
M3,
GCS of 11. You were managing, and now the patient has suddenly gone to E1, V2, M3.
even V2 and M3. That means GCS, total GCS is 6. That means I'll go for intubation for airway protection.
Okay, what else?
Then I'll see why the GCS has dropped suddenly. I'll repeat the CT. I'll see and if there is increasing or not.
CT was done 2 hours back.
Okay, so immediately
Your person is already coming. Your neuro
so
person is already on the way.
so I'll intubate this patient. I'll assume means the cause of this drop in GCS could be the this raised means rise this increase in bleeding only. So I'll immediately shift the patient for the definitive management, that is clipping or coiling after securing airway.
Okay. So the patient underwent endovascular coiling for the aneurysm and shifted to ICU with the same GCS for further management. Now, post coiling, what are the salient points of further management of this patient? Patient has been coiled. Patient has again come to your ICU. Now, what specific or what general care you can take of this patient?
So if the now patient is again coming into the ICU, I'll go with the faster BID. I'll take care of the feeding. Then and I mean, patient is obviously then I'll keep the patient paralyzed. I'll take care of the thromboprophylaxis. Blood pressure will be bit on
How
the
will you
higher
take care of
side to
thromboprophylaxis?
prevent the vasospasm.
How will you take care of
So the patient,
thromboprophylaxis?
so patient just have come from the OT and since the patient is of SH, start with the mechanical thromboprophylaxis first, and then after 48 hours, 72 hours, after making sure the size of the bleeding has increased, start with the low heparin.
Okay. What else will you monitor for in this patient?
So blood pressure, so most means the now I'll be managing most common complication, that is vasospasms. So so blood pressure will be bit on the higher side. Then feeding, I'll put the RT feed. Means enteral nutrition I'll start. Then head and osmolality, and I'll also like to check the volume status of the patient. SIDH is more common in euvolemic patient, cerebral salt wasting in hypovolemic patient. So it's necessary to know whether it is because of SIDH or because of cerebral salt wasting syndrome, because the treatment line is different.
Okay. Except CSWS and SIADH, is there anything else specific in this patient which could lead to sodium of 125? Just go through the history once more, the first page. Can you find something? Okay, fair enough. So now the patient sodium is 125 and you have sent urinary sodium, but the patient needs to be managed till urinary sodium comes. What will you do?
So till so the urinary till that I'll just and if it is SIDH,
Okay.
so
Hypertonic saline.
3% row that is expected sodium minus
Body
current
weight
sodium.
actual or predicted?
Sorry, sir.
Body weight actual or predicted?
Body weight.
Okay, move ahead. Move ahead. Yeah, 0.5 to body weight then.
So this current the expected sodium minus current sodium, and then according to that I'll start the correction.
Okay. Do you know anything about Monroe-Kelly doctrine?
So,
Hello. Monroe-Kelly doctrine. Okay, something related to three things in the brain and their,
yes,
you
sir.
know,
Monroe-Kelly doctor, and it is related means skull is heart structure, and inside the skull there are three components, that is blood, brain matter, and the CSF. So there is if there is any rise in one of the component, then the brain is trying to compensate for that by shifting the other component. If there is a means if there is a rise in pressure because of the brain parenchymal pathology, then the brain will try to compensate and maintain the pressure of the ICP by displacing the CSF or the blood.
what is cerebral blood flow autoregulation? So the thing that you explained, it can be explained better, and its name is Monroe-Kelly doctrine. What is cerebral
Yes,
blood flow autoregulation?
so cerebral blood flow autoregulation means the uh, this the pressure inside the brain, it depends upon the body pressure. Whenever the body pressure increases, the pressure inside the brain will also increase, but then the brain will try to regulate the blood pressure so that uh, it won't means, sir, I cannot explain in the proper way brain autoregulation.
Now I can't tell you to draw it right now. Okay. Okay. How can you measure raised ICP? What is the gold
So
standard?
for measuring raised ICP, there are two methods: invasive and non-invasive. In non-invasive, we'll go
No,
for
what is
the
the gold standard?
uh, gold standard.
Okay. What are the various methods of raised ICP?
So there is invasive and non-invasive. In non-invasive, we are going for the optic nerve sheath diameter and the CT scan. In invasive methods, we'll go for this transcranial Doppler is also the non-invasive one, and uh, uh, invasive
Okay,
we
what
are
is the normal value of ICP?
22 mmHg, less than 22
So if I have an 18 mmHg, then it is normal.
less than 22 mmHg is normal.
Okay. How do you manage raised ICP in terms of tired approach?
So tier 1 will be the tier 1 consists of sedating, mechanically intubating patient, sedate and paralyze, put the invasive lines, then manage the electrolyte. Tier 1 will then if the patient this ICP is not controlled, then we'll go for the tier 2, that is managing the CO2. PaCO2 should be in the range of 25 to 35. Then we can go for the this lumbar this CSF drain, and we can consider the decompressive craniotomy, and
So
we
when
can
you do CSF drain, is it not one of the better measures of measuring ICP also?
intraparenchymal catheter we can see intraparenchymal catheter
Drain.
we
We were
can
talking
measure the
of
ICP
drain.
by intraparenchymal catheter.
Okay, continue.
Then then if the this ICP is not controlled by this measure, then we can consider the decompressive craniotomy. Then in tier 2, then if the ICP is still not under control, then we can decrease the PCO2 concentration further. That means we can keep
What
the
is the minimum? What is the minimum level beyond which we should not decrease PCO2?
Yes, 25, sir. PaCO2 should not be less than 20
Why so?
because it will cause the vasoconstriction, and then it will cause the more ischemic. It will cause the more ischemic injury to the brain.
So your patient had a GCS of 11 and was post-intervention presented to your ICU. 6 hours, 8 hours, 10 hours later, the patient has developed new onset weakness of right upper and lower limb with decreased GCS of 7. What could be the differential?
Okay, so if there is a weakness and decrease in GCS, it could be because of the new onset. It could be because of the vasospasm.
Except vasospasm, anything else?
It could be new onset bleed can be there.
Yeah, that is one thing. So rebleed. The
Rebleed
second
and
one is
vasospasm.
DCI. Third thing,
Delayed
basic
cerebral
investigations. Would you like to repeat again?
transcranial Doppler.
Okay. 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 So what is the difference between vasospasm and DCI, delayed cerebral ischemia? Hello.
Yes, sir.
So what is the difference between vasospasm and delayed cerebral ischemia? Is there
Sorry,
any
sir.
difference?
Sorry, sir. I could not remember.
Okay. Is there any role of nimodipine?
Yes, there is a role of nimodipine to prevent the vasospasm. It should be started from the day of admission till day of 21. The
Dosing?
main role is to prevent vasospasm, sir.
Dosing?
Dosing is 40 mg every 4 hours. 40 mg, 60 mg every 4 hours.
For how many days?
For 21 days.
Okay. So your patient had this GCS of 7 with right upper limb, lower limb weakness. You went for a TCD, then you went for a CT. The patient was having DCI. How will you treat it?
There is
With passing time, the ischemia is increasing, ma'am. Start treatment.
so so first is like the hydration, and then we'll go for the therapies like milrinone, and if they're still not
No.
controlled, then
Okay. Okay. Any role of transcranial Doppler?
yes, transcranial Doppler we can done to know the to predict whether patient can go for the vasospasm or not, because
Anything
clinically
else?
focal figure won't be there, but transcranial Doppler can pick it up early.
Any ratio that we can take up from transcranial Doppler, which you know of?
Sorry.
Any ratio that can be measured by transcranial Doppler of different vessels, which you know of?
Yes, sir. Yes, sir. Lindegard ratio. So the ratio is consist of the blood flow velocity in the MCA and ICA. If this Lindegard ratio is more than 6, then that is the predictive of vasospasm.
Okay, so your patient didn't respond to treatment. Her GCS became 3 in the next 2 days, and the patient is now having a urinary output of 300 to 400 ml per hour since last 2 hours. What will you do?
So probably this patient is going into diabetes insipidus because the urine output is high. So, and the GCS become 3. So I would like to examine the pupils of this patient. Then motor exam, then the other motor examination I would like to carry out, like response to pain or so. What is sir pupils or status of the pupils and the motor examination? Can you tell me the details?
What are the confounders of brain death?
Confounders of the brain deaths are hypothermia, then snake bite, GBS, hyponatremia, hypotension.
Any drugs?
Any drug?
Drugs.
So if the
Medicines.
patient is on the high sedative like benzodiazepines, then we it can come as for.
So you eliminated all the confounders. You by yourself as an ICU intensivist thought of brain death. Now, how will you declare of it?
So you are not audible, sir.
Hello? Hello?
Hello, sir. Now,
Hello? Can you listen? Hello?
Ashwini, we can hear Dr. Vidur.
Dr. Ashwini?
I think Dr. Ashwini,
I think the
with
tar
network
is
issue.
having some network issues.
Yeah.
Okay, we can end. Last 2 questions I remember. If at all she comes back, we'll go through the questions.
I think you open the questions so that the candidates can and we will analyze that the overall So Vidur and Dr. Jain, both of you. Vidur, you
Good evening,
start.
sir.
Huh.
Good evening, sir. Yeah, so she's a 50-year-old lady, diabetic, and presented with these things. The main thing that she missed out was sugars at the start, which should be one of the preliminary investigation. Otherwise, she was fair enough with the other investigations and the primary management. Regarding her differential, also she was okay. She could have included meningitis, she could have included stroke, encephalitis, things like that. Along with, means actually she can go for a DD of altered sensorium.
Yes.
Any differential. Okay. She was right to point out the blood pressure and heart rate. So Cushing's comes in play, and that is how she went to the CNS primary pathology. I think it can go either way, but I would not like to comment on the ECG in terms of trop. That would complicate the issue, especially in exam. When we are discussing, that is a different thing. In exams, if you will go towards that, then if the examiner is a little bit off mood, or he's already had too many students who have given the case of SH, he would go towards Takotsubo and global cardiomyopathy and things like that, which we would not like to go off at the start. So rather than that, just cerebral T waves, which do occur in SH, and we close the topic, right, sir?
Yes. Okay. Yeah.
Okay.
Or just
And
yeah.
okay. Then coming to the CT, I think where she could have added that CT should be followed by CT angiography, and CCT brain should be followed by, which is a minimum to answer. At least that is what I think. Then there is one thing that you should read. I don't know whether it may be asked or not, but I think that is important because it has been mentioned at many places. That is CT negative and clinically strongly suspected SH. So there comes the role depending on duration. If the patient is presenting subacutely, then LP has a role. If the patient is presenting acutely, then you need to go for a repeat MRI because nowadays FLAIR, DWI, GRE sequences are there, which are good enough to give a second opinion in a negative CT, strongly suspected SH. So I think we should be knowing a little bit about that. Regarding LP, the answer that I could manage was that there is no definition for a negative SHLP. So lumbar puncture in SH is negative only when no RBCs are there and no xanthochromia is there. In more than 5 into 10 raised to 3 RBCs plus xanthochromia, the suspicion of SH increases. Okay, what is xanthochromia is a fairly simple question. One more thing, if the examiner goes a little wayward, you should know a little bit about xanthochromia, why it happens, and things like that. Classification, simple. Initial management, you need to mention about maintaining euvolemia, controlling blood pressure, neurointerventional call ASAP, and you need to also add one line that is counseling the patient's relatives. Not that as a student you don't focus too much on that, but yeah, SH has a very bad prognosis, so you should include that in the initial management. Along with that, definitive treatment, clipping versus coiling. I think the best evidence of clipping versus coiling when to do was in SH Guidelines 2023 AHA. There are very specific indications. Like, so clipping versus coiling, coiling is preferred, but clipping is done especially when there is more than 50 ml of intraparenchymal hemorrhage, when there is an MCA aneurysm. That is where clipping is preferred. And coiling is preferred in other patients. Again, WFNS grade 4 and 5, coiling is more preferred. Age more than 70, coiling is more preferred. So clipping versus coiling, coiling is preferred. That is a very basic. If at all the examiner goes a little deep, you need to have a little bit of idea. Okay. aneurysm, IPH, these are the IPH volume. These are the things where clipping can be done. And one more thing where we could have been better was where there are not only 2 treatments. So okay, any specific indication, evidence for indication of clipping? Yeah, it is there. I don't exactly remember it. That is why I told you the guidelines. They have specifically mentioned 3 points I remember, which I told you. Evidence, I don't remember as of now. For clipping, indications were clear. More than 50 ml IPH and MC aneurysm is where clipping is done. And bottleneck aneurysm is where clipping is done. Okay. Yes, where was I? Clipping, coiling. Yeah. So there are not only 2 treatments. Clipping and coiling are more preferred. Stenting is also one thing which is done. So we don't start the answer like there are only 2 treatments. Clipping, coiling, and stenting. Stenting is not preferred, higher morbidity and mortality. But when clipping and coiling cannot be done, neurosurgeons do go for stentings. Okay, early and delayed complications of SH is easy. How can risk of rebleed be decreased? I think that is an important question. We need to answer in terms of hypertension, early aneurysmal repair, and prevention of seizures in those patients who are seizure prone. So that actually brings us to the next, that is indications of prophylactic anti-epileptic in SH patient. So poor neurological grade, hypertensive, large SH, and 2 more indications are there. That is where early prophylactic anti-epileptic can be given. Serum electrolyte report of sodium. Hello, am I audible?
Yes.
Yes, yes.
Is there any, I'm actually going continuously, so I just interrupt. Anything you want to add, sir, you want to modify, because
No,
these students are
that's
going to be.
fine. Yeah.
Okay. Serum sodium 125. So definitely you're going to answer SIADH and CSWS. What I wanted in this patient maybe was because is diabetic and glucose hyperglycemia can lead to pseudohyponatremia. Your raised ICP treating with mannitol on a higher dose can lead to pseudohyponatremia and a mixture of etiologies. So these things, adrenal insufficiency, that can lead to hyponatremia. So when you are asked for differentials, you can proceed like SIADH should be the first one to tell. CSWS, adrenal insufficiency, pseudohyponatremia from mannitol or hyperglycemia, and last, a combination of these etiologies. Regarding the treatment of, suppose the next question was sodium is 125, and what is the treatment? So the first thing that I would like is euvolemia and 3% NS, irrespective of the etiology. Normally, we are not able to differentiate clinically on a very urgent basis between CSWS and SIADH, but the treatment doesn't change majorly, in SH at least. So in SH, hyponatremia, euvolemia, and 3% NS. Right, sir?
Yes.
Okay. Monroe-Kelly doctrine was fairly simple. Cellular blood flow autoregulation, you should know to draw the graph. If at all you're not able to explain, that should not be the case, but if at all you're not able to explain, draw the graph where it's like this, and at a critical juncture, the ICP starts rising more than the CPP. Why is it important? Because that point is actually where your targets of raised MAP came to maintain MAP, so that to maintain CPP in the event of raised ICP. So that is where the importance comes. How will you measure raised ICP is where I do not think we can go wayward. It should start with a standard non-invasive. There are 6. Then there is invasive, gold standard. How will you manage raised ICP? Tired approach is there, and that was not explained very perfectly. Okay, so head of the bed and elevation, sedation paralysis, no necktie, and no cuffing that the patient does. Then comes the role of your these things, anti-epileptics. Then this actually PCO to hyperventilation. Then comes the role of decompressive craniotomy. Then comes the role of poikilothermia and barbiturates coma. So it's a very uh, very, very clearly mentioned the tired approach, and I think we should go towards that so that any wayward question which we are not able to answer, standard questions when we answer, the examiner would be satisfied कि हाँ, he knows standard things at least. Anything else to add, sir, up till now?
No, no.
Okay. Develop new onset of weakness, right, both lower limb, upper limb. So differentials, you would never speak vasospasm as one of your differential. That is my understanding. So we have delayed cerebral ischemia. There's a difference between vasospasm and DCI. Most of the patients who are of SH, they will have some amount of vasospasm due to the oxyhemoglobin which is there. But of those, 50% or some percent, 50 to 60% of those patients would develop clinically significant vasospasm, and they would go in DCI, delayed cerebral ischemia. That is one pathway. Second, in spite of no vasospasm, there are multiple mechanisms by which a patient may go in DCI, delayed cerebral ischemia. So read that in a little detail, where there is microcirculatory failure, there is anatomical variation, lack of collateral, then there is cellular dysfunction, things like that, along with vasospasm, will result in DCI. So there is a difference between vasospasm and DCI. Role of transcranial Doppler should be very specific. So my idea is that transcranial Doppler is for screening every day, depending on the severity, either OD or BD, means once a day or 12 hourly, and we try to see changes in peak flow velocity and Lindgard ratio. Depending on that, we try to identify those subset of patients who may go into DCI. And we try to early diagnose those subsets and treat them in terms of hypervolemia and maintaining slight hypertension. Right, sir?
Yes. Yeah. I mean,
And then, yes, sir.
no, no, agree. Yeah.
And then when the patient goes in DCI actually, then you have to, if the patient doesn't have a cardiac problem, if the patient doesn't have a blood pressure related problem, you have to maintain slightly hypertensive. And after that also, if the patient doesn't improve, we need to plan for vasodilators for distal vessel and proximal vessel angioplasty, stenting and angioplasty. That is the treatment of DCI. Okay. One more thing was there, that is the role of oral nimodipine. So oral nimodipine improves your neurological outcome. It does not decrease the frequency of vasospasm. You should be a little careful, slight. Well, as a resident, I also used to make this type of mistake, but if we can highlight those points, fair enough. Oral nimodipine dosing, Dr. Ashwini had told. Treatment of DCI, okay. Brain death and things like that. So in brain death, one thing which I wanted in this was that we cannot declare brain death as an intensivist. We would require another non-treating doctor to come and declare it. Things to add on, sir.
No, I think you explained well about subarachnoid hemorrhage. I think you have explained most of the, I think, subarachnoid. From a brain death and organ donation counseling to the relative, that was my role, or what do you want?
Overall.
Yeah, okay. So subarachnoid is very important topic, which is commonly comes as a part of either viva or as a long case. You need to know mainly evidence for and which therapy to be used in this scenario. There are many treatment options are being tried to prevent the vasospasm, like aspirin, beta blockers, simvastatin. RB topic was very well covered in this.
Severity assessment, the scoring system interventional neuroradiologist or neurosurgeon itself to fix the issue. Basic management and clinical management and clinical monitoring, both basic and advanced, till the time you have clipped it or coiled it. Then what happens next? How to prevent, you have said, the delayed complications, how to monitor, if there are any other issues, how to manage the complications. The complications can be multiple: hydrocephalus, bleeding, vasospasm, and all others. There could be also stress cardiomyopathy, which is not that uncommon because there are a lot of subendocardial ischemia and stress cardiomyopathy in subarachnoid hemorrhage itself. Remember, these are comparatively younger patients. The patient may lead to a poor prognosis. We need to know the prognostic factors or the points, and the patient may lead towards more of a sort of brain death situation too, if there is a bleeding out of it as a secondary complication, or a subarachnoid hemorrhage per se leading to it, and there it could be dragged into a care for a potential organ donor and all that. So one ethical question as well as communication question can arise, that how you are going to break the bad news, prognosticate, what are the prognostication factors, long-term care, if there is minimal conscious state, or even where you can discuss about potential organ donation itself. So this is overall on a subarachnoid. Definitely it would be a long case if it is there in the ICU itself. Yes, Vidur, I think you want to speak something.
So there was a message in the chat. I had to reply. Evidence and dose of intra-arterial milrinol for DCI. So dose, I don't remember. Sorry for that. Evidence. So intra-arterial milrinol has been found to be promising, especially given for refractory treatment. So the first treatment that they give is normally verapamil or nicardipine. Nicardipine is more preferred. And when the patient is still refractory on that, then intra-arterial milrinol is to be tried. Promising results are there, but still no guidelines have been formed on that.
Or the many times, if there is a significant, as Vidur mentioned, if you are monitoring transcranial Doppler and it shows that it is consistent with the significant perfusion issues or vasospasm, then you can do intervention radiology, check angio, and then if there is a significant vasospasm is there, local or intra-arterial verapamil or diltiazem are being tried as well for improving the vasospasm. But whether that improves outcome or prevents delayed cerebral ischemia, there are some studies that shows it can, but there is no strong evidence in favor of that. But yes, doing a DSA and injecting local calcium channel blockers have been tried.
Sir, we'll move over to the next.
Yes, to the next. Are we ready with the short case? Who is in the short case?
Yes, sir. I'm in the short
Dr.
case.
Dipanjan is the examiner, and Dr. Prithviraj is the examinee.
Okay, so 15 minutes for the exams, and then we'll take the discussion part. Regarding, I think, one questions, indications for specific indications, I think Mayur very nicely answered. Intra-arterial milrinol, we have also an A. But these are all your options. Very difficult to have a very established the indications for all this. But it has been used at times. We have also used it with varied success, but it goes into a. But if you are, these are all your honest question. If you stick to your basic ideas, basic principles of management, I think you would secured the pass marks. That's
most important is basic questions, right? Yeah.
Okay, because a lot of we are sort of goalkeepers, right? If we can upkeep the physiology, we keep the patient alive. We know the principles. We discuss. We have the adequate knowledge to discuss with the specific super specialist about it. Follow their what they wish to do with the particular patient itself, and support them to the certain extent. At times also guide them to do the perfect procedure at the perfect time, right? Then I think that's an A. That is what expected from in an exam itself. Okay, so let's go to the short case. Thank you, Vidur. Excellent work.
Thank you, sir.
Thank you.
Yeah.
Dr. Vidya, if you can stop your presentation. Just to stop sharing. Thank you so much.
Okay, Dipanjan is the
Okay.
examiner,
Yes.
right?
Yes. Good evening,
Good evening.
everyone.
And
Good evening,
who is
sir.
the candidate?
Dr. Prithviraj. Dr. Prithviraj, are you there? Yes.
Where is? Okay, I think Prithviraj would open his camera. Let's see. Very good. Prithviraj Saha. Jago Bangali. Jago Bangali means wake up Bengali. Eh? Good. Chalo.
Hello. Am I audible?
Yes, sir.
Yes.
Yes. Okay. Hello, Prithvi.
Prithviraj is
How
also
are you?
audible.
Yes.
Okay. So today we're going to start the short case. It will be very straightforward. Okay, Prithvi.
Okay, sir.
So it will be I would expect very precise answer and very straightforward answer. Okay.
Okay, sir.
Okay. So your case starts like that. Can you read for me?
A 58-year-old male present to the emergency department with a hematemesis and melena for the past 6 hours. He reports dizziness, generalized weakness, and near syncope before arrival. He had a history of alcohol-related chronic liver disease with portal hypertension. His medications include carvedilol, torsemide with spironolactone, and syrup lactulose.
Okay. And on examination, you got this kind of
Patient
features,
is hypotensive, tachycardic, and tachypneic with an SpO2 of 96% on room air, dehydrated with dry mucous membrane and altered sensorium, mild distension with shifting dialness and dilated veins over abdomen, signs of CLD, with rectal examination of black tarry stool and the point of care ultrasound found. Liver altered echo structure, dilated portal vein suggestive of portal hypertension, ascites, raised cortical echogenicity, a bilateral kidney, bilateral mild pleural effusion, EF of 55%.
Okay. So how will you prioritize this patient? The patient came to emergency at your hospital. So how will you prioritize this patient?
At first, sir, I will go for, as in the ABC approach, I will look for the airway, as the GCS is 13/15. So most likely the airway will be protected, but the patient is hypotensive. So I will be look for the airway breathing, and then I will go for the circulation. I will establish 2 large bore cannula and will start with the IV fluid and start resuscitation of the patient.
Okay, so what kind of fluid you are going to prefer in this case?
In this case, I will prefer, sir, balanced salt solution. We can use normal saline initially, but we can use balanced salt solution also.
Okay. So any evidence of doing, but how will you lead? It is crystalloid versus colloid. What will you prefer?
I will use crystalloid.
Any evidence for that?
Balanced style. Balanced style, right?
Sir, crystalloid versus colloid. in this hemorrhagic shock.
Yes. So, in risk stratification of this patient, how will you risk stratify this patient? There is also a question of risk stratification. Is there any scoring system, or is
There
there
is,
any kind of
sir,
hemorrhagic shock? You are already suspecting patient is in hemorrhagic shock.
sir,
Is there
for the
any
risk
classification?
satisfaction for hemorrhagic shock, I will classify according to the grading of the patient. As the patient has already hypotensive, so the patient has already lost almost more than 40% of the blood. So the categorization of in the hemorrhagic shock will be class 4. Also for a upper GI bleeding, I will classify according to the Glasgow blood scale or
Glasgow, yes.
Glasgow scale or pre-endoscopy Rockall score.
Good. So can you enumerate any kind of what are the points in the Glasgow scale?
No, sir, I don't remember at present.
Okay, just read it. Okay, no issue. So for fluid resuscitation, you prefer crystalloid Berylstone solution for that. For the evidence, you have to look for what are the evidence. Later on we'll know. So in the debriefing session, so we'll first start with the IV fluid bolus with fluid resuscitation. So any pharmacological therapy you would like to start from at this point?
Yes, sir. I will start with tarlipresin, or as the patient is a known case of CLD, so there is a high chance of having variceal bleed. So I will start with a vasoconstrictor tarlipresin of 2 mg QID at a dose of 2 mg QID, and also there is also subsequent chance of having ulcer bleed in these patients. So I will also give an 80 mg bolus of pantoprazole and will start with an infusion of 8 mg per hour.
Okay. Anything else you have to add in your treatment chart? Apart from you have already mentioned IV fluid, you have already mentioned.
And I will also add an antibiotic in this case because in this upper GI bleed in chronic liver disease, there is a chance of SVP. So I will add third generation cephalosporin.
Good, good. So any specific evidence for using terlipressin over other vasoactive analogs?
Trial, I don't know.
No, there is any upper hand of terlipressin? Why you are using terlipressin? Why not somatostatin? Why not octreotide?
Because it is a potent splanchnic vasoconstrictor.
Okay. So is there any evidence behind it? You don't know. Okay, we'll come to that also. What is the relative contraindication for terlipressin?
Sir, relative first before starting terlipressin, we will do an ECG, and if there are any symptoms of coronary ischemia signs or in the ECG, or have the patient having some history or a previous history of mesenteric ischemia or any type of ischemic events before, then we will not be going with terlipressin rather than other options of vasoconstriction.
Okay. So next question is, if you have to intubate the patient, what were the condition? What are the indications for intubating? And what are the specific preparation you will take for this patient?
Sir, before for the indication of intubation in this category of patient, first is the GCS if it's fall down less than 8. Second is the hemodynamically unstable. Third is unprotected airway due to severe upper GI bleed. These are the 3 conditions which I will keep in mind for intubating the patient in early. And also in the in some cases in hemodynamically unstable patient, for doing endoscopy also intubation can help. And for preparation for intubation, I will give sufficient amount of fluid so that during the intubation, the patient doesn't crashes or the patient doesn't goes into hypotension. I will start vasopressors beforehand as the patient is already hypotensive, because during the intubation the patient may land up into hypotension. Thirdly, I will go for rapid sequence intubation with prefixed dose of sedatives and muscle relaxant. And lastly,
what is the induction agent you will prefer in this case?
Sir, etomidate or ketamine.
Okay, good. Anything? And apart from that?
And apart from that, muscle relaxant, rocuronium, what we use. And always this intubation to be done in as the patient is already in hypovolemic shock. The intubation should be done with expert hands and with all the difficult airway devices ready in our hands.
Okay. Good. So you'll preferably go for that LMA also. You'll be taking LMA, and you'll obviously keep help of bougie or steroids. So now on initial investigation has come. So initial investigation shows a hemoglobin of 6.8 and platelet of 90,000 and INR is 2.1. As one creatinine ratio is elevated, LFT is showing albumin is 2.8 and bilirubin is 2.5 gram. And ABG also showing pH is acidotic, PCO2 of 25 and PO2 of 68. And lactate is 2.2. And Apache endoscopy is obviously pending stage. So what will be your blood transfusion indication in this?
Sir, in this case, we will like to have an hemoglobin of 7 if the patient is not having any cardiac disease or cardiac dysfunction.
In that
if
case,
what cannot get you, sir.
If there is cardiac issue,
if there is a cardiac issue, sir, then no, before securing, we will not go much beyond that, but otherwise for the cardiac patients we keep around 9. But as the patient is actively bleeding and the bleeding is not controlled, so 8 to 9 will be the target in patient with cardiac diseases. Then around 9.
Okay. So any role of colloid?
Role of colloid, yes, sir. In colloid, in these patients, we can use 5% albumin for the resuscitation. If there is a huge amount of crystalloid already been used for resuscitation of this patient, so we can use 5% albumin for resuscitating this patient. And at this stage, and after this, in this CLD patient, if the patient develops AKI and we are suspecting some sort of HRS, then the role of 20% albumin comes.
Okay, good. So how would you like to manage the coagulopathy? Any specific role for PCC? PCC means beta-prothrombin.
So 2.1 INR is 2.1. At this point, I will not correct. I will not chase the INR in this case.
Any role of PCC? Anything role of PCC? If at what point you can start off with correcting coagulopathy or with evidence of UD?
If at all I have to do, if I have the facility in our hospital, what we can go for a TEG, and we can, but this is an acute situation. So, but in CLD, we generally do not correct coagulopathy. We go for a TEG, and in the proper substance which is required according to the TEG, we replace only that. I don't know, sir, role of PCC in this GI bleed. If the
Not
patient is
in,
having
if
on
not in GI bleed and
anticoagulant,
patient is in CLL, patient is in CLD, is at all the PCC has to be given. I think in cases with large volume transfusion has been given, then PCC can be a factor where we have to restrict the volume and PCC concentrate can be given.
and if the patient is on NOACs like this, I don't know.
No, so what are the endoscopic strategies for GI bleed?
Sir, endoscopic strategies for the GI is first, if it is an variceal bleed, the EVL should be done endovascular like ligation. Ligation.
That is.
Sorry. If this due to any ulcer, then injection, what we have seen, the injection of adrenaline on the ulcer base or sclerotherapy or photocoagulation. If the patient EVL is done and the PT bleeds, then we will go for a repeat endoscopy and EVL. Endoscopic strategies, sir, if variceal bleed, then EVL. If ulcer bleed, then use of vasoconstrictor.
Okay.
Or
epinephrine can be used. Or
epinephrine and clipping and photocoagulation.
Now your patient undergone Apache endoscopy and high risk medium large vessels are seen in the lower third of esophagus and endoscopy for post-stratification for post-endoscopy.
Post-endoscopy Rockall score is there.
So what are the components? Do you remember?
No.
Okay. So how will you differentiate between ongoing bleed or rebleed?
Ongoing bleed, sir, there will be return of there will be return of blood in the, if there is a Riles tube in C2, then there will be an return of fresh blood in the.
Okay, there will be blood. You are saying that hematopoiesis will be there. Okay.
The hemoglobin will fall and the patient will have an. Sir, what?
How much hemoglobin fall? At least you will be alerted then. Because already you have resuscitated the patient. And now endoscopy has done and patient has been shifted to your ICU. And now patient again. Yes, 2 point within.
Within, I don't know, 20.
I think within 6 hours is 2 point drop in the hemoglobin, you should alert.
Okay, sir. Okay, sir.
Yes. Okay. And anything else? It gives you a hint, and during endoscopy, is anything you can see that there is a chance of repeat. The high
so
chance.
There is some high risk factors like
high risk lesions,
cherry red spots,
yes, and or spotting vessels in the
spotting vessels.
Yes. Okay. Thank you. Next is how do you manage in this case if the patient develops hepatic encephalopathy? Because you might be knowing that bleeding is one concern. Apache bleed can precipitate hepatic encephalopathy in this patient. And so how do you manage this hepatic encephalopathy and AKI in this patient?
So first,
what are the main battle? Yes.
For hepatic encephalopathy, first, sir, I have to rule out any the precipitating factors which can develop, which can manifest with this hepatic encephalopathy, like any dyselectrolytemia, hypovolemia. I should be correcting those reversible factors. If the patient is in the hepatic encephalopathy 1 and 2, then I will go with the pharmacological treatment only. And I will also send for an serum ammonia And if the patient, I will parallelly check for the ABC of the patient. If the patient is already in the hepatic encephalopathy, I will be using for pharmacological already in already established hepatoencephalopathy. For pharmacological treatment, we can use lactulose, L-ornithine, L-aspartate, or oral chain branch amino acids. We in our ICU use lactulose and to ensure 3 to 4 soft stools, and also L-ornithine, L-aspartate, Lola as a sachet.
If your patient is in AKI, would you like to use that?
No, if the patient concurrently having an AKI, then we will not be using, but because that can cause hypermagnesemia or AKI in this patient. If the patient is also having AKI, so in this first we have to resuscitate the patient and correct the volume of the patient. If then after then also the patient is having persistent AKI, then the suspicion of hepatorenal, and also we have to exclude the infection. If the patient is having
Sepsis,
any
yes.
sepsis, UTI, any other cause which can precipitate AKI in this patient, then we will be starting, if all the causes are excluded, then we will be starting the therapy for the hepatorenal syndrome, taldepressine infusion, and with albumin, volume expansion with the albumin. But before that, we have to exclude all the reversible causes which can precipitate AKI in this patient.
Okay, thank you. And what are the predictors for poor prognosis in this patient? How will you prognosticate a patient's relative in this case?
Predictors of
What are the clinical predictors that will give you the hint that patient might be complicated?
one,
Apart
once the patient is in an advanced stage of CLD, the CTP scoring and MEL scoring. Number 2 is that as the patient has come with an upper GI bleed, the hemodynamic status of the patient, and along with that any adjoining with the concurrent presence of any sepsis or septic shock, like SBP or spontaneous bacterial peritonitis. Thirdly, if the patient rebleeds again, then we have to consider for EVL, and if not, again we have to consider.
So patient is having ongoing bleed.
Ongoing bleed, yes, sir.
And any other comorbidities also. Okay?
Any other comorbidities, yes.
Malignancy or comorbidities like hypertension,
yes.
CVD, syndrome. Okay, pretty good
Thank you, sir.
answering from Petri. Thank you. So can you start the debriefing session? Hello? Am I audible?
You have to share, you have to share the debriefing presentation.
Okay.
Arindam sir.
Sir, Arindam sir, anything?
Performance?
Yes, sir. Yes, sir.
User, rapid transfuser, maybe warming devices. And all sort of, which could be common also in any trauma situation or a trauma case.
Prevent the coagulation.
An early institution of blood transfusion.
And I was happy that he commented on that the intubation also, right?
Yes.
Also, whether rapid sequence or delayed sequence, right? There could be certain discussion on that part. But as an intensivist, your work is to maintain on a rapid upper GI bleed sort of way. So nowadays endoscopy, but most of the times practically the scopist will wait for the patient to stabilize, because going inside and in a acute bleeding situation, at times you won't get to see anything. So that is also an issue sort of a. Regarding this tubes, SB tubes and all others, or the Minnesota tube, na? The other
Minnesota.
one. Procoagulation, lasers, a lot of options are available. Just have an idea of what then you to reverse the patient itself. At times also, correction of coagulopathy could be
That's it. Okay. Thank you, sir.
Thank you, Prithviraj, for coming forward.
Thank you, sir.
Okay.
Thank you.
I think should we take should we do a table before going to the short case?
I'm ready, sir.
Dr. Devijan, what sir is asking that sir wants to.
Yeah,
Then I'm
I'm ready.
just asking.
If sir wants to start,
If you
let us.
you were okay with it.
No, it's okay, sir. Let us have a table because continuous
Okay.
cases are going.
Now,
I
if
think
you are in
they
a
might have
hurry, you have
covered.
to go somewhere, leave somewhere. Otherwise,
No, sir. I'm.
you are here, right? So,
No, sir.
Ritika, are you here? Are you
Yes,
ready?
sir. I'm completely.
Dr. Ritika? No, then you start. Ritika is here to be ready. You do the short case. Who is the candidate for the short case?
So you have to choose.
No volunteers.
Now I think they should be.
I think
No
someone
volunteers?
auditioned for it, but later on withdrawn his name.
Okay, so can someone come forward?
Yeah, lots of people are there. At least 70 participants are there.
Can someone please volunteer and come forward?
Let us nominate.
Gurkirat Singh Bedi, right?
Hello, good evening, sir.
I cannot see you. This is
Yes, Dr. Gurkirat is here.
Gurkirat, yeah.
Yes,
Okay.
sir. I'm online, sir.
You're volunteering. Okay. So
Yes,
you
sir.
can
I will
also.
give it a shot.
Okay, fantastic. So you open up the camera itself if it is possible.
I don't have the presentation of the case, sir.
No, you
Maybe I'll
don't need
No,
start
you
reading.
don't have to. You don't have to. That we will do. You have
Okay,
to
sir.
just face the camera and give us the answers. That's it.
Yes, sir. Can I
Look
keep the
like.
camera off, sir? But I'll
Okay, take care.
answer actively.
Okay, we are fine. Okay, Dr. Devijan is going to be your examiner, and he is
Yes, sir.
going to share the screen and discuss the questions itself. Devijan, it's all yours. Go on. Not being able to hear you, I think you are muted.
Hello, ma'am.
Devijan, you have to unmute and you have to
Share,
share
sir.
the screen.
Waiting
No,
for
ma'am. No,
screen,
So
sir.
sir.
please share and unmute yourself.
Yes. Carol.
This case has been prepared by both Dr. Devijan and Dr. Sunil Kedia. Both of them have.
जाओ 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 मैं तो तभी तो बोल रहा सॉरी
Division, kindly unmute yourself.
Can
Is it
hear
visible, sir?
Dr. Kedia,
It's
are you
unmute,
there?
ma'am.
Is it?
Yeah, you are audible. You just
Hello?
Yes. We can hear you.
It's audible? Yeah. My screen?
No, your screen
The
is not
screen
visible.
is not visible.
Can you see my screen and slides, sir, please?
Not yet.
It's visible for me.
You need to share.
You're
Yeah,
doing the
I
right thing. Can you
did.
kindly share?
Now? No.
Yeah, just
Okay.
give us a minute. It is.
Sorry for the technical glitch. Now is it visible?
This you have started screen sharing, but you open your
Actually,
presentation.
Dr. Devijan's
Now,
internet is not proper. Dr. Devijan, if you can kindly switch off your video.
how it is visible?
Not yet.
This is more, and then there is no chest pain, so it is predominantly going towards chest pathology rather than a cardiac pathology. Yes.
Okay, fine. This is the past medical history and the medications which you want, some more history which has been given, after which we'll go to the differential diagnosis and further.
Yes, sir. Yes, sir. Sure, sir. The patient has had past medical history of hypertension. Patient had history of similar episode 4 months back and got admitted in some other hospital. Upon discharge, he was started on inhalers. He was advised regarding smoking cessation, to which patient was non-compliant. The patient takes formoterol, telmisartan 40 milligram daily. Sir, that page is gone.
Sorry. This is same
The
thing. Okay.
patient has no known drug allergies. The patient has smoked 2 pack of cigarettes per day for last 45 years. Sir, this history is pointing more towards chronic obstructive pulmonary disease, as there is no seasonal allergies. There is a personal history of 2 pack years of smoking, and he's having he's having multiple, he's had admissions before also with similar episodes, and the cough was the chronic symptoms and inhalers were ongoing, and there is an element of hypertension also. My differential will be of chronic obstructive pulmonary disease, bronchial asthma.
Any other differential diagnosis which you would like to entertain in the emergency room to rule out the other emergency
Sir, I
conditions?
would like to rule out heart failure,
Very good.
sided heart failure also, and
Right.
other than that,
Okay, fine. So what will be your probable diagnosis? As you were saying,
there
it
is
could be
no,
a
if there is no fever, I'll rule out like the breathlessness related to sepsis, that the patient is immediately just crashing like situation. That is why he's having breathlessness. Or pneumonia, I'll try to rule out pneumonia. That will also be one of my differential.
Very good.
Probable
Fine.
diagnostic testing at point of care, I would like is to I would like to go with basics of first of all airway, breathing, circulation, as his airway was threatened. The diagnostic test at point of care I would like is chest X-ray and
Okay.
RBS If I
And
have a lung ultrasound, I would like to proceed with that to rule out any B lines, any
okay,
cardiogenic edema.
good.
Just an immediate quick look at the inferior vena cava diameter, left ventricular outflow tract (VTI) to get a good look at the kind of
Okay.
left ventricle uh, I'm dealing with, and the right-sided heart's diameter, so that I can go more towards
Mm-hmm.
my diagnosis of pulmonary hypertension must be there with the COPD patient is there. Then I would like to do the workup for sepsis and infection because there is exacerbation. I am suspecting of COPD. It must be related to infection. Though there are non-infective reasons of exacerbations are also there. Spirometry if possible, and
Okay.
IgE count for ruling out, and eosinophil
No,
count.
no,
I'm
we are
my
yeah, good.
CBP.
We are only diagnostic testing at point of care. So I'm asking more specific investigations at that point of time, which will give you help you for the diagnosis. Yes, I would like to send all the IG levels and
Lung
all
ultrasound,
after
sir,
that.
I would like to do for B lines, lung sliding, rule out pneumonia.
Right. That's it. Anything else you want to do?
Uh, Sir, I would
Okay.
stick to basics for
Your other senior has come up and he has suggested you for 2 investigations, and these are the 2 investigations.
trail blood gas. Definitely, I would go for to look out for carbon dioxide level, CO2 level, and
So, yeah, this is the chest X-ray of that patient, and this is the ABG analysis, which are the bedside. And focus point of ultrasound, yes, we'll have a discussion about it. But these two are now present. Just
sir,
can you go with the X-ray and the ABG analysis?
sir,
Quickly
on
and quick
X-ray,
ones.
X-ray is on looking at the X-ray. It seems to be AP view. There is lung hyperinflation is there. The cardiac silhouette looks little straightened, though there is not that much of a tubular heart, but the lung hyperinflation component is there. On the right, there is no signs of any ground glassing there. On the right side in ABG, the ABG is suggestive of severe metabolic acidosis, severe respiratory acidosis without respiratory compensation. As per Winter's formula, the CO2 of 90 is supposed to bring the bicarbonate to at least 29, which is 26 here. And with that, there is lactate of 5. So if I subtract the lactate contributing to the fall in bicarbonate also, there is mixed respiratory acidosis with metabolic acidosis contributing to pH of 6.93.
So, what
And
do
with
you
that,
think
the
the causes of
hypoxemia
this?
is also there. Hypoxemia
Yes.
is also there. Uh, uh, this hypoxemia could be from rise in CO2 causing the alveolar gas equation. Since patient must be on 21% of the FiO2 of the room air, this carbon dioxide is causing this reason of hypoxemia at the moment.
Okay. What could be the
Yeah.
cause of metabolic acidosis for this kind of a patient?
Sir, metabolic cause of this patient could be, sir, hypoxemia.
The
Is
lactates are coming from where?
lactate. Sir, fluid deficit at the moment. Maybe volume deficit is there.
Okay.
Yes, sir.
Okay. Fine. So now the simple questions, and we are going only with the questionnaires and only the point of questions will go. It's not long, it's just a short case. So how will you define the COPD of any COPD patient? So what are the points you will try to pick up?
Sir, COPD patient, sir, as per GOLD criteria, patient
Yeah,
having
good.
cardinal
Very
symptoms
good.
of
Very good. Come on.
cough, sputum, breathing difficulty, which is more than the baseline. There is a baseline cough is there. There is increase in the sputum quality.
Okay.
the quantity of the sputum has increased. The cough has increased, and breathing baseline
That
breathing
is the
difficulty.
definition of exacerbation.
Yes, sir. Expiratory
Gurpreet,
flow
that is the
limitation.
definition of exacerbation. Yeah.
Sir,
What is the definition of COPD? And what is it?
it
You
is
are telling me the
obstruct-
definition of exacerbation. I'm asking COPD definition as such.
Sorry, sir.
That-
Sir, COPD will be defined with obstructive airway disease with characteristics of smaller airway disease, expiratory flow limitation with increase in end expiratory lung volume.
Okay. How will you define or classify the severity of COPD according to the GOLD only?
Sir, according to GOLD, we will use FEV1C criteria. FEV1 over FVC will be less than 0.7. And then there are further 4 categories, which is dependent on the FEV1 FEV1 percentage of the baseline of the normal predicted value of FEV1 should be there. Like it is FEV1 of 80% predicted grade is mild, moderate is 50 to 80. Then there is severe, and very severe is less than 30% of the predicted FEV1.
Yes, fine. Now, how will you define the acute exacerbation in a patient of a diagnosed case of COPD?
Sir, there will be increase in baseline symptoms, increase in the sputum has increased from baseline. There is purulency has increased. The cough has increased. There is more of a wet cough. Breathing difficulty has worsened from baseline. With that, the documented expiratory
That's
flow.
a good thing. Now, after exacerbation is there, now how do you assess the severity and how will you go about with the etiologies of exacerbation of COPDs?
Sir, severity I've already discussed. Etiology,
No,
sir.
that is an assessment of severity of COPD. I'm asking the assessment of severity of exacerbation of COPD. Is there any way to do that?
Sir, bedside with help of arterial blood gas.
Okay, good. That's a good start. Yes.
Because there will be expiratory flow limitation that is going to have caused the severity here. So
Okay,
there are multiple admissions. History of multiple admissions is there.
Okay.
Patient having hemodynamic instability is there.
Is there any specific protocol for this, or is there any specific guidelines for this, or any proposals which are given previously? It's okay. Fine. So when you see a patient of acute exacerbation of COPD, the etiological points, the main etiological points which you like to check for this exacerbation is a diagnosed case of COPD. Now we have diagnosed it by all the technologies. Now we have got to the etiologies. So what etiologies you would like to check mark first?
Sir, I would like to check for whether this the etiology is because of smoking, biomass fuel, and whether at the moment in the time
What's the
point
cause of reason for exacerbation? The etiology of reason for exacerbation.
Sir, exacerbation, I would sir like to check by sir whether it is caused by infection. Most common cause of infection is Haemophilus influenza. Streptococcus pneumoniae is also there, but H influenza is most common. But if there are regular admissions are there, multiple patient is in the exacerbator group, there are regularly he's having exacerbations in a calendar year. I would like to think of Pseudomonas also, and ABPA also, and I would like to think of on the lines of pulmonary aspergillosis also.
Okay.
Rule in and focus.
So scores COPD?
No.
These scores are regularly used for the prognostication or mortality predicting and the like allocation of the patient to where he has to go. Any scores, you know? Major question also. So we have the patient here. What like steps we follow for an acute exacerbation of the emergency and definition to is in your ICU right now. So how will you manage?
Men based
Hello, sir?
on the 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 priority that if the patient of COPD crashes, reason
We have the
COPD
patient here,
patient
61-year-old. You have the patient with already ABC. It has been given to you. You have an ABG right now.
yes,
So how would you go further?
sir, if there is if patient is hemodynamically unstable because of dynamic hyperinflation, autop uh, flow limit is very severe, and I would now there when the GCS is low, I would secure the airway and put him on controlled ventilation with the tidal volume of 400 because the lung compliance will also be low, and try to keep more of the expiratory time constant so that patient can get
We will
rid of
set the
the
ventilator.
carbon dioxide.
Hi, Gurpreet. We will set the ventilator later. I want what steps you want to follow. All the steps. Then we'll go one step again.
Uh,
First, you
Sir,
said
first of all, I would like to, sir, secure the airway.
very good. That
Go
is
for
very important.
a breathing
Yes.
component. Yes, sir. Look for the breathing component. Try to keep more of expiratory predominant breathing so that CO2 could be washed out. In circulation, I would like to, sir, see whether patient is wet or dry, uh, whether there is uh, 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 whether the cause of COPD is due to any infection or sepsis, pneumonia is there, whether the volume depletion component is not there. Maybe use some hemodynamic monitoring at the bedside, whichever is available. With that, I would like to investigate uh, with tracheal secretions, chest X-ray, CT chest to rule out ground, to see for worsening ground glassing, and with that I would proceed. And then for reversible component, I would like to start with bronchodilators, uh, s- uh, uh, and sir, levosalbutamol, 1.25 milligram 6 hours. And after these initial steps are taken, and if the CT chest is suggestive of infective origin, I would like to start antibiotics. I would like to cover with BL-BLI combination, piperacillin tazobactam for this patient, anti-pseudomonal cover with that atypical cover if needed, and uh, 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 sir, after that, my priorities will be to manage dynamic hyperinflation, and if patient is stabilized with all that, if the GCS
Where
is
will you
fine,
dispose the case? Where will you dispose this case, current case? Where will you dispose to, like ward, floor, discharge?
sir, since 6.9 pH was there, I'm suspecting his GCS will also be low. He will go to ICU as hypoxemia was also there. Type 2 respiratory failure is there.
And airway was also potentially
And
threatened.
airway was potentially hampered, sir.
Yes.
And that.
So didn't start any steroid till now. Is there any role?
Yes, sir. Role of steroid is controversial, but if
Okay.
the reversible component is there, which can be manipulated, the role of steroid is there in COPD, in airways.
Mm-hmm.
uh,
Mm-hmm.
Small airway. That because the pathology here is of radial traction destruction, and alveolar wall injury is there, alveolar wall destruction is there, but that the sum of the reversible airway component can be manipulated with steroids. The recommendations are up to 60 milligram of prednisolone
Which
and
steroid? Okay, prednisolone you want to use. Okay.
intravenous.
Uh, any other steroids? Hydrocortisone I would like to use. Is there any benefit of that?
Hydrocortisone, sir, I would like to use hydrocortisone. Uh, and there also could be, since there are multiple exacerbation, there could be, sir, adrenal insufficiency also. So I would like to cover with hydrocortisone predominantly. Uh, and um, sir, nebulization,
Yeah.
inhalational corticosteroids also have role, but if the expiratory flow limitation is very much severe, then they will not reach the airway.
Okay, good. So which steroids you prefer then? IV or inhalation?
IV, sir.
IV.
1
Systemic
milligram
steroids mostly.
systemic steroid,
Hmm.
60 m.
Now he's in your ICU and you are called. You are the floor in charge now. No, I'm asking. NIV is helpful.
Sir, yes, NIV is helpful in patient with
How?
acute exacerbation. Sir, NIV will help in overcoming three pressures: P resistance, P elastance, and the auto PEEP component, decrease work of breathing. And if we can calculate the auto PEEP using expiratory hold in when the patient was on controlled ventilation, and we can use that PEEP, and we can calculate, and we can use the 80% of that auto PEEP to
No, in
help
NIV. We are in
NIV.
NIV. We didn't intubate.
Sir,
We
we can
didn't
use
intubate.
that data on our NIV. We can exploit that data on our NIV later, and
Okay.
that
For
will
this
help.
patient,
Yes,
yes,
sir.
yes, good.
NIV is
For
helpful.
this patient, go back to the first slide again. Airways potentially threatened, pH 6.9. Now, can we use an NIV in this patient? If yes, how?
Initially,
If no,
NIV
how?
shall not
And
be used.
NIV in various phases also, in acute exacerbation, in various
Yes, sir.
phases where you can use. This is the question clear.
Initially, I won't like to use NIV in this patient as airway was threatened and CO2 was 90 and patient needs immediate intubation. Maybe later when on, if there is chance of extubation, and
Good.
we
Very good. Now comes your main thing which we are discussing till now. How do you set up a initial ventilatory settings for this patient, and how do you monitor further?
Sir, I would
So I want a
start.
complete ventilator settings.
Yes, sir. I would start with respiratory rate of up to 12 to 14, tidal volume of 400, in IE ratio of 1:3. PEEP initially I would like to keep around 5, and flow settings of around 60 to 80 liters of flow in volume control ventilation with square waveform. Uh, and if needed, patient, I will, for ventilator desync, to avoid ventilator desynchronies, I would like to sedate the patient. For monitoring, I would do, sir, serial ABGs in this patient. and keep saturation around 88 to 92%. And
So you will do ABGs for what? To see which parameter?
sir, serial ABGs will be done for CO2 washout to check for hypoxemia, respiratory acidosis.
Okay. Can these two things can be done non-invasively nowadays?
Sir, with
Non-invasively,
help
can
of
these two things can be done?
sir, with the help of ETCO2 monitor, we can
Very good.
get the idea of how much CO2 we are washing.
So again, the same question: should we take and repeated ABGs for this patient or not? We can use it ETCO2 as a surrogate marker for the ABG.
Sir, if the dead space is increasing, then we'll have to need PCO2 also.
PCO2. Okay, fine. Any other monitoring tools you would like to use, which is in and around your ICU, and which will be beeping all the time?
Sir, basic
In this patient, it will be being very high.
Pulse oximetry.
Saturation, okay. Okay, those things are done. Monitoring any other thing. Leave about the 12-lead monitor. Apart from that, beyond that. Okay, now suddenly something has happened and your ventilator started beeping very high.
Ventilator graphics I would monitor
what is happening
for these. Yes, sir.
Yeah, in this what is happening suddenly, this is the graph which you are seeing in your ventilator, whatever ventilator you have. I mean, in the sense which company you have, these graphs will be the same.
Yes, sir. Yes, sir.
So
sir,
just go through the graphs.
The first one is pressure time scalar. It is suggesting of raised peak airway pressures while plateau pressures are within normal limits. Peak pressures are increasing more than the plateau pressure. The difference between peak and plateau is very high, maybe due to obstruction, and this is not touching baseline in flow time scalar. So there is element of auto peep in this patient.
And in the volume time?
Sir, volume also is not touching baseline. There is dynamic hyperinflation.
Auto peep is, yes. There is a dynamic hyperinflation component is also going on. My case.
Yeah.
So this patient is being managed by you. You are giving continuous nebulizations, and somebody suggested from ECMO team stating that we will start an ECMO in him. Is there any role?
Sir, extracorporeal system in managing COPD, sir, there are evidences for this. There are evidences for use of a core machine, ECCO2R for removal. For that, there was recent
studies
trial
which they
also
have done
for that.
directly.
Yes. Sir, there was trial also.
So did it show any benefit?
Sir, mortality benefit was not there, but CO2 removal was there were decreased ventilatory time. They were able to wean quickly using by manipulating. You first trial, not sure of the name, sir.
Okay. So now oxygen therapy targets come into the picture. What is the rationale for it?
Oxygen therapy, sir, I would like to keep in range of 88 to 92 because there are three factors which can lead to problems here. Increasing by giving oxygen, increased oxygen will further increase CO2, and patient will decrease further, will deteriorate further. There is Haldane effect. There is a Haldane effect. Then number two, there will be the shunting will increase. The hypoxic pulmonary vasoconstriction will be inhibited. And number three, there will be a decreased ventilation because of oxygenation. It will inhibit ventilation. Yeah. Yes, sir.
So pulmonary, you are saying that drive, respiratory drive is
Drive will
lost.
go down. Drive will go down.
Okay. Any other reasons? Okay.
Sir,
That's
but
a good
still
thing.
oxygen is needed. If we won't give oxygen, then PCO2 will keep on
So
increasing.
what are your
And
targets? What are
alveolar
the
gas
targets?
equation will shift then 88 to 92%.
Okay. Good.
Otherwise, patient will get anoxic if we won't give oxygen, and then if we use the alveolar gas equation 0.21
Mhm.
multiplied by 713 minus PCO2 divided by respiratory quotient, the PCO2 component will overtake the alveolar gas equation, and patient can have
Okay.
severe anoxia. So that is a thing where there is a role of oxygen, but we cannot give too much oxygen also. So
The
our
targets are
target
88 to 92.
is to 92. Yes, sir.
Okay, good. Fine. So now coming on to your daily FASTag bits. In that,
Yes,
one of the thing is thromboprophylaxis.
yes,
What is
sir.
so special for acute exacerbation of COPD, where thromboprophylaxis is like one of the mandatory thing which they always suggest? It is a daily protocol, you use it, but in this there is something else we have to add. Why?
Pardon, sir. I didn't get the question.
The role of thromboprophylaxis in acute exacerbation of COPD. For every ICU patient, we use a thromboprophylaxis as a
Yes,
fast
sir.
tag bed,
Yes,
right?
sir.
So in this, is there any special studies or special things which were seen? So where there is acute exacerbation, thromboprophylaxis is added as the treatment protocol. Is there any special pathophysiology which is happening here? The
Sir,
increased risk of DVTs?
patients are having polycythemia. Stasis can happen.
Okay.
There will be more.
Mhm.
There are more chances of patient having arrhythmias, pulmonary hypertension, and right-sided heart is going through a lot of
Okay.
high pressure. So their anticoagulant can help uh, in in preventing.
Okay. Nice, nice. You have done very nicely. You have done almost all the questions were fine. Uh, I'm going to.
I think he has done exceptionally well, and that too also coming forward on this. Uh, I think this is more or less we have covered up for two long cases and two short cases. COPD,
Yes,
I
sir.
think ventilation strategy, then your standards, steroids,
Yes.
precipitants, use of antibiotics, role of whether procalcitonin based and all this stuff. Then uh, NIV would be a big A, right? Anything,
Big.
all details regarding use of NIV, then escalation or de-escalation, basic setting, A setting, rise time, anything and everything can be asked on that part. IPAP support,
Yes, sir.
EPAP support, then details of it can completely go into NIV related on A. Then when to intubate would be a very favorite question from us examiner.
Yes, sir.
Then particularly the ABG based or whether it's a combination of ABG and clinical profiling and all others. Then while on the ventilator, the deliverance of inhalational therapy, right, particularly the vibrating mesh technologies and all others, if you do not have that, where you can place the
Your nebulizer.
MDIs, beta dose inhalers, and all others. So you guys can read a very nice article by Rajiv Dhand, Dhand. He's a guy who has done immense work on inhalational therapy while being ventilated. Right. So both were on invasive as well as non-invasive ventilation, important humidification, inhalational therapy, and all others. The other rescue therapies, I think like magnesiums and all others, including the Anaconda devices delivering the sevoflurane and others. Very recent article has come on that part. We also have an extreme situations, indications of extracorporeal therapies, both a full-blown ECMO itself or a concept of ECOR itself
Got
along with NIV can also be asked. Read about a little bit on the supercapnia. and also in difficult situations when to consider tracheostomy, whether that gives you a sort of help and an aid. Then other rehabilitation process for a chronic COPD patients and all others. So this is it could be easily a long case if there is so.
Yes, sir.
But in the month of April, May, COPD may not be present itself. But we just wanted to include this one because it could be a prototype situation, and any patient with little bit of respiratory difficulty, bronchospasm or something can be put into, and the questions can be equally same. So thank you, Dr. Gurkirat, for coming forward, and excellent moderation by Dr. Devijan. Thank you both.
Thank you, sir.
So we will
Thank you,
quickly
sir.
do one set of tables itself, right? We will try to get, I think we are a little late, but we will try to get it quickly. So I invite Dr. Ritika, who is a consultant here in Reliance Foundation. She made the entire sort of the question set, both the table sets. So she's going to quickly ask, let's see how many we can do. And I want a volunteer to come forward. Anyone? Come on, guys, you are going to take exams in few days' time. Don't be shy, don't be hesitant.
Sir, Dr. Pratap Reddy was volunteer for, he said that he want to volunteer for acute exacerbation COPD. So that time
Okay, so
Gurpreet
let's
has
take
done.
Pratap,
So
come forward.
Pratap Reddy Muthalya.
Okay, Dr. Pratap, please come forward. Ritika, are you ready?
Yes, sir. Yes, sir.
So you are going to share, or Atul is going to share?
I'll request Sudeshna only to share because some of the images
Yes.
are not available in
Okay.
that PPT.
Fair enough. So the idea is Pratap is going to take at least couple of sets. The first set is you are starting with X-ray, CT scan, all these images, right?
So yeah, first set is ABG, mechanical ventilation, and airway. Yeah.
Okay. I think Devijan, you have to stop sharing, unshare.
Yeah.
Yes.
And Pratap, you can also open up your camera if you wish to. Ritika, I know, has some difficulty. He's
Yes, sir.
with the kid. So ABG, airway and ventilation. So this is only one set, right?
Yes, sir. So
Of
this is one
ABG,
table. We
ABG,
have
airway
5 tables in total.
okay, fair enough. Let's
15
start
minutes
with this.
each.
Okay.
But we will try to be a little faster because already. ये वाला बंद हाँ ठीक है.
Pratap, you're okay?
Yes, sir.
So
Okay, all the best.
yeah. So let's start, Dr. Pratap. Our first case. Just read out loudly and answer the questions.
A 50-year-old man has severe community acquired pneumonia. He has been on non-invasive ventilation for 2 hours and now requires intubation. The following gases are obtained before and after intubation. Interpret the blood gas analysis. Why has
that is the question. That is the question.
Yeah.
You
So
look into
ABG.
pre-intubation and post-intubation.
Yes.
FiO2, one in
Pre-intubation
both.
FiO2 1, PaO2 87, PaCO2 27, pH 7.23, bicarb 13.4, standard base equivalent minus 13.7. pH 7.23 means acidosis, and bicarb is less, so metabolic acidosis. So we have to calculate the compensation. Compensation for compensation, we have to use Winter's formula.
We have just wait for the question, Pratap. The question first is why the oxygenation has
Dr.
improved.
Pratap, your questions are already there. Interpret the blood gases. Why has his oxygenation improved? What is the A gradient and what why he has got water for post intubation? So this is your question.
Okay, ma'am.
Can we mute Dr. Vidur? Yeah, thank you. Yeah, Dr. Pratap, go ahead.
Yes, ma'am.
My
Is
stopwatch is on. I'll move on to next questions otherwise.
why has his oxygenation improved?
You can see his oxygenation has improved post-intubation.
Yes, madam. 87
Intubation
to
also 100%, post-intubation also FR to 100%. Why is oxygenation improved?
7.0.
Okay, next question. Why? What is the AA gradient? Can you calculate
Yes,
with this?
A gradient. P. I forgot the formula, madam.
Okay.
Sorry.
Why has he got worse following intubation?
Is PSCO2 is increased because of community acquired pneumonia. It went to ARDS picture, madam.
But you intubated because he was worsening, but post intubation you expect that it should get better. He worsened. Okay, we will move on to next question. Next question.
Krishna, next one.
At 2 a.m., the night intern brings arterial blood gas sample of ICU from 71-year-old man who is on the medical ward with lobar pneumonia. She is worried he has received too much oxygen. What do the gases show?
So interpret this ABG.
pH is 7.15, S-dose is, and bicarb is 22, which is fairly normal. PaCO2 is 65, means respiratory acidosis.
Anything else along with respiratory acidosis?
And we have to see whether it is acute respiratory acidosis or chronic respiratory acidosis. Acute respiratory acidosis for 10 mm of Hg, pH change is 0.08 has to change. So 35 at 0.24. It's a acute respiratory acidosis, madam.
Okay. Along with anything else or only acute respiratory acidosis?
And we have to see the metabolic component, whether it is compensated or not.
Is it there?
For metabolic component, 10 delta H by.
Yes.
Okay. How will you advise the intern to adjust the oxygenation because he's worried about too much of oxygen? Why intern is worried about too much of oxygen? Okay, next question.
A surgical patient had a stormy course in the ICU following colonic anastomotic breakdown. She has been ventilated for 2 weeks and has tracheostomy. She is in the process of being weaned. The following arterial gases are obtained. What are likely causes? pH is 7.44 and PaO2 84. PaCO2 is 53. Bicarb is 30. Base excess is +10. How does this gas influence on weaning?
So what is the likely cause? What is your problem here?
Surgical patient had stormy course ICU colonic anastomotic breakdown.
Of ABG, what is the problem?
It's pH is more than 7.4, so alkalosis. So bicarb is more than 26, so metabolic alkalosis.
Very good. Okay, next.
Compensation. respiratory acidosis.
Okay. So what are the likely causes for how does this gas influence weaning? Is it going influence the weaning problem?
Yes, madam.
Why?
Because alkalosis, some electrolyte disturbances may occur.
Then so
diaphragm muscle dysfunction may occur.
okay.
Alkalosis, hypokalemia may occur.
Okay. Can you do anything to change it? Change this ABG? What treatment you will do? Okay. Next question.
Identify the problem, how to correct it.
Well, once again. I think Sudeshna's image is not available here. I share.
Yes. 1 second. I'll just give me a minute. Shumo. रातुल तो स्क्रीन बंद कर, शेयर बंद कर.
Yeah.
I think
so identify the
to
problem.
discuss all together, right? All the graphs and ventilation graphs. Fair enough. Okay.
Sir, after end of this
after
table.
Once you end this 15 minutes.
Yes. Yes, sir. So identify the problem.
It's
No.
Yes, ma'am.
Next. Next question. So can you identify the problem here? This is the ventilator graph,
Yes,
right?
Is a scalar.
So pressure time scalar and flow time scalar.
Yes,
so what is the problem here? It's clearly shown with the arrow. Arrow is pointing towards the problem.
Yes.
Next. Here, can you identify?
Secretions.
Yeah. So what is happening with the secretions? You can see now what is happening with the secretions. Identify this device.
Is Venturi mask.
What are the variable performance and fixed performance oxygen delivery systems?
Oxygen delivery has to be fixed.
Fixed and fixed performance. Example?
Face mask, simple face mask.
So simple face mask comes under variable or fixed? Okay, so can you answer about the Venturi effect? Okay, next question. This is one line answer. 45 year.
45-year-old male patient presents to the emergency department after severe motor vehicle accident. He has multiple facial fractures, extensive soft tissue swelling, and bleeding from his mouth. The patient is struggling to breathe with stridor and SpO2 82% with despite high flow oxygen. Endotracheal intubation is attempted but fails due to significant swelling and anatomical distortion. A second attempt with video laryngoscope is unsuccessful. The patient oxygen saturation drops to 70%. Bag mass ventilation becomes ineffective. What is our next step?
So
then we will go second line supraglottic devices, madam.
But already he is having bleeding from his mouth and facial bone fractures.
Then we will cricothyroidotomy.
Needle cricothyroidotomy, yes. Next.
58-year-old male with the history of COPD underwent elective tracheostomy 5 days ago due to prolonged mechanical ventilation. He is currently in the ICU on weaning protocol. During routine bed repositioning, the patient suddenly becomes agitated and tachypneic. The nurse notices that tracheostomy tube has been accidentally dislodged. The patient oxygen saturation drops to 78% and he starts on gasping for air. Next step in the management.
So here problem is
tracheostomy
dislodgement.
Tube.
So what you are going to do?
Then we have to, first we have to bag mass ventilation. Then we have to change the tracheostomy tube.
So how old is the tracheostomy tube?
Is 5 days ago electrotracheostomy was done.
How many days it takes to form the tract?
1 week.
More than a week, 1 to 2 weeks, yes. So is it going to be easy thing to again reintroduce the tracheostomy tube? Patient already oxygen saturation is dropping till 78%. So what ideally you should do?
Endotracheal intubation.
Yes. I think this is the last question, no? For this table. Yeah. So we'll come up with the answers. Starting with the first question. So first question, सुदेशना मैडम आप आंसर्स का ओपन कर रहे हो या फिर इसका ही फर्स्ट क्वेश्चन आप लेकर आ रहे हो? So Dr. Pratap,
yes,
you need to work on it for sure.
Yes,
but don't worry, you will improve for sure. That's why we are conducting this. Okay.
Yes,
so just practice with the time management. So our first question was pneumonia patient, 100% FiO2 pre-intubation and 100% FiO2 post-intubation. Pre-intubation oxygenation was 80 on post-intubation, oxygenation improved, but acidosis worsened and PaCO2 worsened. So our question was interpret the blood gas. Of course, this is a hypoxia. We all forget to mention about the hypoxia in ABG. Okay, so you have to mention hypoxia and acidosis along with hypercarbia. Now, prior to intubation, severe metabolic acidosis with respiratory compensation, then respiratory acidosis following intubation. His A gradient, you have to remember the formula. Okay, the alveolar gas equation. So it was prior to intubation was 593, pre-intubation 537 after that. Now oxygenation improved. Why? Because intubation, now controlled ventilation, reducing the oxygen consumption, improved respiratory mechanics, improved oxygen delivery, and improved hemodynamics. These all contribute to improvement in the oxygenation. Why his acidosis worsened, especially that is a respiratory acidosis that contributed? Because initially the metabolic acidosis was getting compensated by tachypnea. The patient was compensating, right? So CO2, you will see it is 22 or 24. But post-intubation, that's the reason we need to set the ventilator as per the patient's pre-intubation condition. Because if with this ABG, we are intubating and setting the ventilator with a respiratory rate of around normal 16 to 18, with the tidal volume of 9 to 10, where he requires 9 to 10 minute ventilation, where he requires minute ventilation of 18 to 20, in fact, to compensate for the metabolic acidosis. If we are undercorrecting it, definitely CO2 is going to get worsened and respiratory acidosis worsens. At times, that can cause respiratory arrest, cardiac arrest also. So you have to be very careful while setting the ventilator. Next question. Next. Okay. So this is 71-year-old male patient admitted, which, one second, question. 71-year-old male patient was admitted in the ward with hypoxia. He was on 8 liters of oxygen. So ABG, which was done, that is showing CO2 is high, 53, PO2 84 acceptable, but don't forget that patient is on, no, before that, this, no, not this one, before this. So with 8 liters, so hypoxia is there, PCO2 is high. Now we don't know in this patient whether the CO2 is chronic or not, acute, because 71-year-old, it can be acute or chronic also. But you will see bicarb is not compensating for the high CO2 in any condition. Okay. So, and that too, if the patient is chronic COPD kind of patients, then you will expect bicarb to be on the higher side. So come to the answer. Come to the answer part. So there's marked acidosis and CO2 is high. Respiratory acidosis, we will expect the bicarb to be on the higher side, base X, but here base excess is low, indicating the coexistence of metabolic acidosis. So this is mixed acidosis picture. Now PO2 is acceptable, but definitely A gradient is increased. So there is a significant lung parenchymal problem. So, and along with that, type 1 and type 2 respiratory failure. Now this patient is very sick and needs oxygen. So as I told you, we don't know why I asked that intern is worried about the oxygen, because if it would have been a COPD situation, then as discussed in the last short case only, increased oxygenation will worsen your CO2 condition. So that's why it's not very easy to say here, but bicarb is on the lower side, so it is indicating more towards the acute condition. So that's why not to worry about this level of PO2. So, and definitely reducing the oxygen is not appropriate. Next question. So surgical patient, STOMI ICU course. Now pH, alkalotic side, PO2 is okay. PaCO2 is little on the higher side. Bicarb is high. So what are the likely causes? Definitely there is a metabolic alkalosis, along with, if you will see the compensation, there is a respiratory acidosis. Come to the answer. So respiratory acidosis, CO2 is higher than the expected respiratory compensation alone. So this indicates marked alkalosis and coexistent respiratory acidosis. Now metabolic alkalosis in this kind of patients, you can expect reasons for that. Volume depletion, because surgical STOMI course, large volume of the nasogastric aspirate, diuretics use, dialysis, all these, and steroids also, these contribute to the metabolic alkalosis part. Respiratory acidosis, because a long time in ICU post-op. So definitely we can expect, one is because of the compensation, CO2 is little on the higher side, but definitely compensation will not happen above 55, because this will stimulate the ventilation. But above 55 means respiratory acidosis could be because of the respiratory muscle weakness also. So metabolic now weaning difficulty can happen because metabolic alkalosis will impair the respiratory drive. So we can here use acetazolamide or dilute hydrochloric acid to normalize the correct the metabolic alkalosis part. Next question. So here, this is the flow time scalar. So the arrow that is showing, it is reverse triggering. Okay. So reverse triggering, just why it happens whenever there is a controlled ventilation, patient is sedated, but this controlled ventilation is causing involuntary respiratory effort. Involuntary, okay, because double trigger is voluntary. involuntary respiratory muscle movement, so that will cause reverse triggering. It can cause breath stacking, so that's why it is a problem, and can hamper the ventilation as well as weaning also. So here, how you are going to correct it? If you think that you can come down with the sedation, decrease the sedation, or decrease the respiratory rate, increase the inspiratory time, or if you cannot decrease the sedation, then sedate and paralyze the patient. Next. Yeah, done. Next. So this is identify the problem and how will you correct it. Now you can see flow time scalar and volume time scalar. You are seeing the square wave pattern in the pressure time and flow time decelerating pattern. The arrow which is pointing towards is creating a negative deflection in the pressure time and positive in the flow time, but it is not getting converted to the gas flow, right? So this represents ineffective trigger. Okay, so come to the answer. Because patient is trying to trigger, so that's why there is a negative deflection in pressure time scalar, but it is not getting converted to the delivery of the gas. So why this happens? Because of the trigger, if the trigger sensitivity is low, so we have to increase the trigger sensitivity, making it more sensitive. Like if suppose you have set the triggers of flow trigger sensitivity of 5 liter, you might have to come down with the 2 liter, because this can happen because you have set the sensitivity of 5 liter. Patient maybe because of the weakness, he is not able to generate that sensitivity. So you have to make it more sensitive, come down with the trigger sensitive, that value. If there is any auto peep, correct that. If patient is sedated, again, decrease the sedation, and of course, check for respiratory muscle weakness. Next. So here it is, I can see, means I have made the question. So I know this is a PRVC setting. And you rightly said about it, there is secretions which is causing tachypnea. And obviously regulation of the pressure limited is coming. So definitely, I'm sure tidal volume generation is also on the lower side. So we have to suction, and then mostly it will get corrected. Next. Yeah, next. So this is your high frequency oscillation ventilator, HFOV. Okay. So next, come to the answer. Nowadays, it is not used in adult, but definitely it you should know about it, because there are 2 RCTs also on this ventilator. So you should know, and that too related to the ARDS. So that's why you should know at least this instrument. It is HFOV, high frequency oscillator ventilator. Principle of working, low lung protective ventilation in ARDS in adult patients, of course. And it's high frequency with respiratory rate of 180 to 900 per minute. So high frequency with very small tidal volume, in fact, less than the anatomical dead space. The difference between the normal ventilator and this is, in our day-to-day ventilator, what we are using, it is active inspiration and passive expiration. Here, inspiration and expiration both are active. It maintains constant mean airway pressure, so it prevents the collapse of the airway, and it helps in the lung recruitment. And because very small tidal volume, so it prevents volume trauma and atelectasis trauma. So 2 trials which are done on this are Oscillate and Oscar trial, but not proven to be having any mortality benefit. So you should know at least this much about HFOV. Next. So device, Venturi mask, principle of working, Bernoulli's Venturi effect. What is Venturi effect? You have to know, because this is in use in ICU, not always, but yeah, if it is needed, you should know the principle of working from the exam point of view, of course. So these are color coded with the fixed FI oxygen delivery. and fixed FiO2 delivery to the patient. So principle of working is whenever the air is flowing from a narrow space, it is a physics principle, of course, velocity increases and pressure decreases. So from narrow to wide space, if it is going, velocity will increase, pressure will drop. There are openings in these venturi masks. So once the pressure drops, it will entrain the air from outside and then it will get delivered to the patient. Air entrainment is as per the color coding, which is identifying the narrow space diameter. So that's why it is a fixed device, because it will velocity is here fixed as per the color coding. So air entrainment will be fixed only, not depending upon the patient's breathing effort. So, okay. So that is the principle of working. Variable performance and fixed performance devices, again, because variable performance like nasal cannula, you can come to the answer. Nasal cannula, oxygen mask, NRBM. Why variable performance? Because your FiO2 varies with the patient's breathing effort. If patient is tachypneic, your flow is less, or you're changing the flow, FiO2 will vary. Fixed performance oxygen delivery device, your FiO2 is not going to vary, because whatever the venturi mask you are using, it will deliver the fixed FiO2, because it will not depend on the patient's breathing effort. Okay. Next question. Okay, this is done. Next. So this is a case scenario. You rightly said needle cricothyroidotomy, because supraglottic airway device will not be a very good idea, because extensive soft tissue swelling is there, bleeding from the mouth is there, and multiple facial anatomical distortion. So it's better to go ahead with the needle cricothyroidotomy here. Next. Sorry, there is one question from Ashwini. Hi, Ashwini. So,
hello, ma'am. Yeah, I have just one doubt. Since this
hi.
patient is having multiple facial fractures,
Yeah.
video laryngoscopy is only already failed. Can we explore the option of fiber optic intubation?
So come to the question.
So can we explore the option of fiber
No.
optic
I'm
intubation?
asking Sudeshna, please come to the question now. Here, see, already patient oxygen saturation dropping to 70%. Fiber optic, because patient is actively bleeding now. If you will put the fiber optic scope now, the vision will not be clear. So that's why fiber optic will not be good here, because already oxygen saturation has started dropping, and there is do not ventilate, do not intubate situation.
Okay, ma'am. Fine. Thank you, ma'am.
Yeah. Next. Next. Dr. Souvik has asked multiple facial fractures. Yeah. Means, are you answering, Dr. Souvik? Okay. So here you rightly said, because here 5 days old elective tracheostomy and tube got dislodged. So, and the patient is gasping with desaturating. So we have to immediately go ahead with the bag mask ventilation followed by oral endotracheal intubation. Because here 5 days ago tracheostomy was done, so we are not expecting that tract is formed. So we will not take the first attempt to put the tracheostomy tube in. First is to save the life, 78% saturation, save the life with the endotracheal intubation, and then you can, if once the patient is stabilized, you can think about tracheostomy again. So that's it for the first table. So Dr. Pratap,
Yes, ma'am.
yeah, work hard on your tables and practice. It will get better for sure.
Okay. Thank you.
So next, who is going to volunteer?
Can I do it, ma'am? I will volunteer.
Yeah, Ashwini. Dr. Gurkirat, next table we will do. Okay.
Yeah, thank you, ma'am.
Yeah. So no. Come back. Previous. This is the answer. Okay. So this is the answer key, na, Sudeshna?
या सोमो ये कुछ हाँ वो चेंज कर 1 मिनट.
So again, my stopwatch is on. sharing?
Yes, ma'am. 1 minute.
Yeah. Yes, Ashwini, we will start.
Yes, ma'am. So
Play the video.
this is the USG scan of the liver, which is showing the distended gallbladder
Okay. Anything else?
with wall thickening and the fluid collection.
Any comment on play the video again? Any comment on these white appearing exudates, like shiny white appearance inside the gallbladder?
Indicative of stone because it is radio stones, multiple calculi are there.
Okay. Next, what you will do? What are the organism responsible for it?
So gram-negative organism, E. coli or Klebsiella, E. coli like.
Okay. And what will be your treatment for this?
Yes, treatment will be definitely fluid therapy, antibiotics, and the definitive treatment will be surgical.
You were saying it's acute cholecystitis, right?
Yeah, with gallbladder is quite distended.
Yeah.
Could be fluid, could be gas. So
yes,
definitely it is infective. So immediately I'll start with fluid resuscitation, antibiotic, and then a definitive plan will be after hemodynamic stabilization. Definitive plan will be surgical.
Okay. Next.
Ritika,
Yeah.
just interrupting you. Can you just clarify that why this is not stomach, distended stomach? Why for the candidate?
Liver is also there, no? It's a right upper quadrant USG scan. You can see the liver also, no? Liver and with the liver hepatic vessels also. So I will explain that in the answers. So next, Ashwini, identify the diagnostic procedure. Previous one.
So
there is no video in that.
So this is the 2D echo, in which 4 chamber view is there, in which pointer is towards
Ashwini, again, just see carefully. See all the pictures carefully.
Diagnostic procedure.
See all the pictures.
Okay. Okay. Probe is okay. It is a transcranial Doppler.
Yeah, don't answer in the chat box right now because I'm answering
Ashwini. Transcranial Doppler. So interpretation, I don't know, ma'am. How can it is a transcranial Doppler.
So, transcranial Doppler, what we interpret?
So transcranial Doppler is for the identification of the raised ICP for detection of the vasospasm.
Okay. Yeah. Okay. So this graph interpretation you won't be able to do?
No, ma'am. I don't know.
Okay. Okay. Next. And where you keep the probe for the transcranial Doppler?
Temporal lobe.
Temporal?
Temporal lobe.
Lobe.
Yeah, lobe, yeah.
Okay. So next, 56-year-old woman admitted with pneumonia, new onset hypotension on day 3 with shortness of breath. ECG demonstrates widespread precordial ischemic changes. Play the video. Play the video. Sorry, this window is not very proper, but at least I think some amount of idea you will get. So, Ashwini, just what is
yes, ma'am. I'm trying to identify.
Hello.
Window.
Yes, Dr. Vidur.
Hello.
Dr. Vidur, you're audible.
Yeah. You wanted me to speak something, ma'am?
No.
No? Okay, done. Thank you.
Ashwini.
Ma'am, can you play the video because it's not at all clear? This much only.
Yeah.
So I can see the poor, okay, I can see the poor contractility, and since the patient develops sudden hypotension,
View first. What
so
this
this
and what is the view?
this is parasternal long axis view, and I can see the right ventricle, right atrium, this
The
opening,
right
and the
atrium you see here in parasternal
right
long axis.
sorry ma'am, right ventricle I can see upper,
Mm.
left ventricle
Mm.
opening, and left
And
atrium. Right
and
atrium
one more thing is aorta.
aortic opening.
Aortic opening is there.
Yes.
So what is the problem here?
So record
Again,
your
the video one last time. Can you identify the problem? What about the LV contractility?
It's any original wall
So
motion
yeah, what
abnormalities.
about the LV contractility?
LV contractility is definitely poor.
Any specific
Original
pattern
wall
you
motion abnormalities.
can see? Okay, next video. So what is the view and what is the problem? We lost the connection.
Recording
I
in
didn't see the
progress.
video.
What all you can see?
So this is again parasternal long axis view. I can see the thrombus in the left ventricle.
Thrombus where?
Left ventricle.
Left ventricle thrombus. Anything else? So what are the structures you can see here? I cannot point out on by arrow because I'm not sharing it. Okay, next. What is this? No video.
This is TAPSE.
Okay, good.
Okay.
And what does it shows?
This is a low, means TAPSE must be less than 15 mm.
Yeah. So RV dysfunction. Yeah.
RV dysfunction could be pulmonary embolism or any other cause of RV dysfunction.
Next. Video. Again. What is this?
Oh God.
What can you see? Well, just explain the whatever is visible. No? Just explain that.
But there is orange collapse.
Pardon?
Liver, I think. It's a hepatic fluid collection.
Ashwini, just see it carefully. You can see the liver, that is right. What else?
There is a fluid collection, perihepatic fluid collection.
Can you see the contractility?
Yes, ma'am.
So
Contract.
contractility is there. So
Yes, it's a heart image.
yeah, that is the vessel, hepatic vessels. So yeah, just cardiac contract. Anything, any comment on the cardiac shadows? Cardiac image?
Is a dilatation. Overall.
Okay. Anything in the chambers? Ashwini, this is so obvious. You will not get so many hints.
This is RARV dilatation, it seems.
RV is ekdam chipku.
Okay, this is a dehydration.
Ashwini, what is there in the LA?
LA.
Can you see that?
Yes, mobile thrombus is there.
Yeah.
Mobile thrombus in LA, and this
Is
IVC
it
is
very common with this big thrombus in LA? This big thrombus will come in the LA. Even if it is atrial fibrillation patient, you will be able to identify on 2D echo? Nahi, na?
No, ma'am.
Then what it would be? Chalo, next, I'll tell you. Just think, and then if you will get the answer, let me know.
Myxoma, it's tumor.
Right.
Myxoma.
Right. Okay. What is this?
This is consolidation, ma'am. Starry sky.
Okay.
Consolidation. It's definitely shred sign.
Shred sign, yes. So just tell USG lung.
USG lung, yeah, suggestive of the shred sign, suggestive of the severe pneumonia. Means the entire lobe is involved here.
And along with that?
B lines, I think.
Syn pneumonic effusion.
Yeah, yes. Pleural effusion is also.
Yeah. Next. What is this?
Barcode sign, suggestive of pneumonia. Sorry, pneumothorax.
USG lung.
Yes, ma'am. USG
Which
lung.
mode?
This is M mode.
Yes.
This sign is barcode sign, which is suggestive of pneumothorax.
Yeah.
Okay, the one on the right side is pneumothorax, and the one on the left side is seashore sign, which is normal, and the other one is pneumothorax.
Yes. Okay. Next. Play the video.
So, this is the again 2D echo of means apical view, 4-chamber view, and this okay, from my side.
4-chamber view. What is there in the 5th chamber? What is that? Is it 4-chamber view? Apical 4-chamber view?
Yes, ma'am. Apical 4-chamber only. 4-chamber only.
Okay.
I think.
Okay.
So global hypokinesis is there.
Then what is there in the top side?
Okay, it is a diastolic collapse, pericardial effusion, cardiac tamponade. RV diastolic collapse is there.
So, so now I think RV is in diastole. And the chamber is quite visible. It's not collapsed. Anything else you can see? Means you can see the pericardium, and you can see this pericardial effusion is very unlikely seeing this. Minimal pericardial effusion.
Yes, no, it's not pericardial effusion, but yes, RV is very much.
So in other view, what else we can see? If suppose this is not apical 4-chamber, which other view we will get this cardiac view? In subcostal?
Yes, ma'am. Subcostal we can get. This is.
And if we are getting subcostal, then what is that above RV?
It's aorta dissection. Is it flap? Aortic dissection.
Like. Aortic dissection. I think we do that. Okay. Next question. What is this?
Thrombus in the this is this is the demonstration of the Mickey Mouse sign, femoral artery, femoral vein. There is a thrombus in femoral vein. Also femoral nerve weak and abrasion.
The non-compressibility of the femoral vein. I think this is the last question now. We'll come with the answer.
Yeah, we'll share the debriefing answer.
Yeah. So Ashwini, I'll suggest you, if you are, even if you don't know the diagnosis, or if even if you are not coming up with a conclusion, at least say what all is visible.
Yes, ma'am.
Okay, so that will give at least the examiner some chance to ask you the leading questions.
Yes, ma'am.
Okay,
Yes.
so just say what all is visible.
Yes, ma'am. Yes, definitely.
We are sharing that.
Just a second, one minute. Huh? Just a second.
So, okay, you completed in 13 minutes.
There's one request, Dr. Ritika.
Yeah.
It's been post more than 4 hours. Yes, all. So I think we can keep this table as the last and then continue the rest from tomorrow.
So this is the last table?
Let this be the last table.
Sure, it is 10:20. Yeah.
Yeah, sure. So Shoma,
Okay.
please share the debriefing.
ठीक है तो रितिका
हाँ जी sir.
Will you be able to join tomorrow?
Yes sir, I'll join.
enough.
We will start
I
at
think-
6 o'clock.
We will start early.
So I'll start with the
because,
tables, sir.
Tomorrow, what we'll do is that tomorrow we will do the we'll complete the tables.
Yes, sir.
And also the viva. Darshana
Yes, sir.
and you will do that. And maybe on the last day we'll complete the 2 long cases and 2 short cases. Okay, Shubhankar?
ठीक है, fine.
Okay. Thank you. Chalo. So guys, I hope you liked that overall program today. Do not worry. We will try to get you an exhausted list of probable cases and also what to expect in the tables at the end of the closing program itself. Okay, post mock.
Yes, sir.
So all the best. See you tomorrow, guys. Sharp
Good night,
at 6.
sir.
Okay, bye.
Yes.
Thank
So
you,
I'll
sir.
finish up this answers.
Okay.
It's already too late. So yeah, so this is USG, right upper quadrant. This because liver is visible, and this is attached to the liver is this distension. So this is gallbladder along with the gallbladder lining and these rays, fine rays. Inside the gallbladder, it is distended. We can clearly see that. And there are shiny, bright appearing white spots. Effervescent sign, or it is a champagne glass appearance of the gallbladder. So this is a classical of emphysematous cholecystitis. Or come with the answers. So emphysematous cholecystitis. Organism responsible are E. coli, Clostridium perfringens, and less commonly Klebsiella pneumoniae also. Treatment is antibiotics, appropriate antibiotics, and surgical intervention, either percutaneous cholecystostomy or surgical cholecystectomy. But it is an emergency situation. Next. So this is just see, that's why I said see the images carefully. You can see this facial image. Probe is placed at the temporal bone with the marker towards the eye, and we identify the MCA, the red artery which is visible on the color Doppler. That is MCA. Okay. And we will place this Doppler over the MCA and we will see these waves. This is transcranial Doppler. Very good to use bedside, non-invasive method to identify vasospasm, which can cause delayed cerebral ischemia in SAH patients. So this is already discussed in the previous viva of SAH, how to interpret transcranial Doppler. Get it, everything about transcranial Doppler, because very commonly and very much in use now. Next. Next. Yeah, so this is old woman, pneumonia, day 3, new onset hypotension with shortness of breath, ECG changes are present. Play the video. So you can see in this is the parasternal 2D echo with parasternal long axis view showing the right ventricle, left atrium, aortic opening. we will see this base is moving nicely. Apex is not clearly visible, but whatever image is visible here, LV ka, we can see the LV mid and the apical, it's there, but it is not moving very nicely. And if this is a classical picture of Takotsubo cardiomyopathy. So my further question was, come to the answer. So further question was the pathophysiology, increased sympathetic surge. So what in the treatment of this Takotsubo cardiomyopathy with hypotension, how you are going to manage this patient? So if, our first response to hypotension is starting sympathomimetic agents, noradrenaline, adrenaline vasopressors, and inotropic agents. Inotropes will worsen this condition even more because it is beta adrenergic response. So you should avoid beta blocker, or if blood pressure permits, use beta blocker. For hypotension, you can use phenylephrine or IABP. Next. And this time, with time, this gets better. But definitely the diagnostic confirmation is by angiography only. Because here you will see the ECG changes also, you will see the raised cardiac enzymes also, but angio will be normal. Next, play the video. So Ashwini, here you were not able to answer, right?
Yes,
So
ma'am.
this is, you will see 4 chambers. This is not exactly the plaques view, but yeah, this, because in plaques you will not be able to see the RA. Here it is visible. So not exactly, but yeah, probe is in that position only. So you can see RA, RV, LA, LV. Cardiac wise, it is looking more or less okay. There is no issue. This below LA, you are seeing this small circular opening.
Yes, ma'am.
That is your descending aorta.
Okay.
Okay. So descending aorta ke niche you are seeing some collection and this acceleration part. So this is your pleural effusion with
Oh God.
collapsed lung. If this would have been above this descending aorta, this would have been what? This collection. Pericardial effusion. Yeah. So this is how we differentiate in the plaques view, na, if it is pericardial effusion or pleural effusion. Okay. Next. So yeah, this you rightly said. This is 2D echo. We will put M mode on the lateral free wall of the RV, and we get this TAPSE, that is tricuspid annular plane excursion. And as per this excursion, we see whether there is any RV dysfunction or not. Usually it is more than 17. If it is less than 17, it is RV dysfunction. Next. So these all you can easily use bedside, and that is really helpful. Next. So it took long time, Ashwini, to answer this question. There's a very big mass in LA. Now, this is, that's why I told you, okay, this can thrombus very, very unlikely, because if it will be thromboembolic phenomena, no, this is 2D echo only. Because this is LA, this is LV. This is a
epigastric view.
Pardon?
Or subxiphoid view.
Yes, this is subcostal. Okay. So because this large thrombus will definitely, this much will not embolize from the pulmonary vessels. Okay, so this cannot come in the LA. LA thrombus, most common is your atrial fibrillation. Atrial fibrillation कहाँ पे जाकर बैठता है? Blood clot. That is in the
ventricle.
LA, left atrium में आता ना, which is visible.
Left, yes.
Sorry, मेरे mind से भी skip हो गया. That is LA का small appendages. LA appendages में you will see, you will be able to see the thrombus clot. But it's this big clot is not possible in atrial fibrillation. So this, yeah, thank you, Dr. Vishal. So this is the LA myxoma.
Myxoma, yeah.
Okay? Because this is attached. Thrombus will not be attached. It will be mobile.
Mobile.
This is attached. Okay? Next question. Next. This you rightly said. This is USG thorax showing lung consolidation with air bronchogram with shred sign and pleural effusion.
Pleural effusion.
Okay. So, and with B lines which are not the sign of
Part of
pulmonary.
consolidation. Yes, part of consolidation.
Yes. Next. So this, I think इसके आंसर में थोड़ा सा मैंने wrong किया है. Just ignore that answer. So this is you rightly said seashore sign and pneumothorax. So barcode sign. Lung point ऐसा नहीं मिलेगा. Lung point ना Dr. Gurkirat. This will be wherever you are putting the M mode na, one half will be having seashore sign, another half will be having barcode sign. So that is where there is the pneumothorax part. So that will be the lung point. Here I have compared the two sides of the lung. You got it? Next. So that's what I said. Ki lung point, I mentioned it wrongly because that will be one half. In one picture only, one side will be the barcode and the other side will be the seashore sign. Next.
Ma'am, what will be the correct interpretation if we have to speak in the exam that this is
So come to the picture. Come to the previous slide. So this left side, it is showing your seashore sign,
which is normal.
which is normal. The right side
Normal
is
M mode
showing,
of a B line of a A lung profile.
yeah,
Lung.
barcode sign.
Okay.
Okay, so that is showing pneumothorax.
Yes, ma'am.
But mention full USG lung with M mode.
Yes, ma'am.
Next. Next. Okay, so this one, this is again 2D echo, subcostal view, but this is what you are seeing above now. Cardiac wise, it is looking okay. No significant pathology. This is the above this RV, what you are seeing is septated ascites.
Okay.
Yeah.
Okay.
This is ascites because ascites is very gross, so that your liver ke upar bhi if it is coming the ascites fluid na, so this will be the appearance.
Okay.
Okay. Yes, subxiphoid. Next. Next slide. This is rightly mentioned. This is a femoral vein scan showing Mickey Mouse sign and incompressible femoral vein suggestive of thrombus, active thrombus. That's it. So good, Ashwini.
Thank you.
Viva table explanation. Can we get to set one?
Who stopped sharing?
Sudeshna,
Ma'am,
he
is asking the
sorry.
previous table explanation, I think.
Oh, sorry.
Which one?
That ABG and the other one. ABG and this ventilator graphics.
This answer sheets, na, that will be provided. That will be provided.
Answer sheets, no?
So what the answer keys, Sudeshna, they are asking for?
No.
Okay.
This will not be provided. Sorry.
So Dr. Annapurna was there, na, who wanted to ask?
Yes, ma'am.
Yeah, so we will discuss. If you want to again have the discussion, we will do it tomorrow because already it's too late.
Yes, ma'am. Because of network issue, I couldn't follow the set one.
No worry. So we can discuss it tomorrow.
Yes, ma'am.
Okay. Yeah. Okay. Thank you so much, everyone.
Ma'am, one last question. Do we have to prepare drugs also like that? Like
yes.
for 15 minutes,
Oh,
there will
yes,
be
I
drugs
have everything, but because of the time constraints, I am not able to finish it off. I have
No, ma'am. From
there is no time
exam
constraint.
point of view, we have to prepare drugs also, no?
Yes.
Yes, we have to
Drugs.
prepare.
And drugs, you have to prepare each and everything, because in drugs now they are not going to give you 3, 4. At least you expect 8 to 10 drugs. Not
And ma'am,
detail.
about hemodynamics, like Lico,
Yes.
Pidco monitors also, no?
Yes, everything.
Basics you have to know.
Yes, sir.
Principle, at least you
More
know.
than the Lico and Pico, you'll be you'll be mainly asked about the principles and EV1000 views. They can be
Yes,
shown.
sir.
But
So-
they expect the basics from you. At least you can identify
Yes.
what kind of shock it is. They will not ask too much questions in depth.
Okay, sir. And airway, na? Airway 100%
Everything,
in
everything.
detail, everything
Yes,
about
everything.
airway. Yes, sir.
You'll get very less amount of time for these things. So these things should be.
Actually, sir, there is no one to guide us, so that is why there is a
We are
lot of
always there,
problem.
na, Dr. Gurkirat? We are
Thank
always
you so much. We are very lucky because of this. We cleared the theory with help of all this only.
No, this,
Tomorrow we have plenty of time, so I think Ritika can discuss
yes,
all.
yes.